highly sensitive region is a dense network of nerve endings, vascular structures, and muscle. Social stigma often leads patients to details about symptoms in this area, delaying medical consultation. Surface-level symptoms, such as mild bleeding or persistent discomfort, can originate from vastly different pathologies, from minor irritation to internal structural ruptures or occult carcinomas. To understand the diagnostic challenges of this region, we will examine three distinct conditions: acute physical trauma, subacute mucosal inflammation, and chronic intractable irritation. Because different conditions share identical presentations, clinicians must maintain a high index of suspicion to distinguish between a temporary nuisance and a life-threatening surgical emergency. Acute trauma to the rectum and anal canal represents the most immediate threat in this region. These injuries often result from severe high-impact falls, penetrating wounds, or complications during medical procedures like enema administration. The primary surgical objective is to determine if the rupture is intraperitoneal of the pelvic floor or extraperitoneal, occurring below it. Peritoneal rupture allows waste to breach the sterile abdominal cavity, risking sepsis. Management requires an emergency laparotomy to suture the perforation and clear contaminants. To facilitate healing, a protective colostomy routes waste through the abdominal wall, bypassing the injured tissue entirely. These physical injuries require rapid mechanical intervention and waste diversion to prevent lethal complications from systemic poisoning. Moving from structural trauma, we encounter proctitis, an inflammatory condition of the rectal mucosa that carries its own set of biological risks. Proctitis is characterized by tenesmus, an intense, painful, and often unproductive urge to defecate. Instead of stool, the patient may pass blood, mucus, or pus. Clinicians utilize cultures and smears to identify the pathogen responsible. Potential causes include dysentery, gonorrhea, or even secondary tuberculosis. During the examination, this is a critical step. Chronic itching frequently signals an underlying systemic or surgical pathology. This diagnostic tree assumes clinical breadth. Systemic conditions like diabetes or parasitic infections are evaluated. The surgical branch reveals severe possibilities, where itching is the primary symptom for malignancies. Resolution requires treating the specific disease at the root. Pruritus ani demonstrates how a single, persistent symptom can serve as the clinical endpoint for a wide array of disparate and sometimes life-threatening diseases. And from urgent surgical repair of a ruptured abdomen to the identification of microscopic pathogens and the screening of occult melanomas. The anal rectal region demands a wide range of clinical expertise, integrating trauma surgery, infectious disease, and oncology. Procedures like enema administration. The primary surgical objective is to determine if the rupture is intraperitoneal, meaning it has occurred above the pelvic floor, or extraperitoneal, occurring below it. An intraperitoneal rupture allows waste to breach the sterile abdominal cavity, risking sepsis. Management requires an emergency laparotomy to suture the perforation and clear contaminants. To facilitate healing, a protective colostomy routes waste through the abdominal wall, bypassing it entirely. These physical injuries require rapid mechanical intervention and waste diversion to prevent lethal complications from systemic poisoning. Moving from structural trauma, we encounter proctitis, an inflammatory condition of the rectal mucosa that carries its own set of biological risks. By to visualize the extent of the inflammation. The exam typically reveals a swollen, reddened mucosal wall, often accompanied by small ulcers. Clinicians utilize cultures and smears to identify the specific pathogen responsible. Potential causes include dysentery, gonococcal infection, or even secondary. During the examination, biopsies are taken from any ulcerated tissue. Critical step: treatment of proctitis is entirely dependent on identifying the microscopic origin of the inflammation. The final stage of the spectrum is pruritus ani, an intractable and relentless itching in the perianal region. While often dismissed as a hygiene issue, chronic itching frequently signals an underlying systemic or surgical pathology. This diagnostic
The surgical branch reveals severe possibilities, where itching is the problem for malignancies. Resolution requires treating the specific disease at the root. Pruritus ani demonstrates how a single, persistent symptom can serve as the point for a wide array of disparate and sometimes laparoscopic pathogens and the screening of occult melanomas. The anal rectal region demands a wide range of clinical expertise, integrating trauma surgery, infections, and oncology. The lower gastrointestinal tract functions as a sensitive indicator for both localized injuries and broader systemic health. Overcoming social stigma is essential for early diagnosis. Embarrassment often prevents the attention required to identify dangerous conditions. A professional medical evaluation is the only way to accurately distinguish a minor irritation from a condition that requires immediate, life-altering intervention.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
At the very base of the human spine lies the sacrococcygeal region. In early development, as a biological crossroads, this area houses a cluster of totipotent cells. These specialized units possess the biological capacity to form every distinct tissue type in the body, from rigid bone to soft muscle and skin. Under normal, these cells complete their role and stop dividing. But if these signals fail to terminate, the cells multiply into a disorganized growing mass. Teratoma, seen here as a large swelling protruding over the back of a newborn. It is the most common tumor found in neonates. Because this mass originates from totipotent cells, it retains the ability to complex anatomical structures, sometimes growing rudimentary limbs like hands or feet deep inside the tissue. If left attached, the physical toll on the infant is severe. The massive growth causes ulceration, blocks the rectal canal, and risks secondary infections and malignant transformation. Surgical excision is the only way to stop the mass from obstructing the rectum or become. This cross-section shows the cramped geography surgeons must navigate. The tumor is wedged tightly between the sacrum and coccyx in back and the rectum in front. Looking closely, the mass is firmly attached to the coccyx and occasionally aimed at the sacrum. Facing the risks of infection and malignancy, surgeons perform the excision as soon as the diagnosis is confirmed. The procedure starts with a longitudinal elliptical incision. Surgeons lift the skin and subcutaneous layers to expose the dense bulk of the mass underneath. From there, the team must separate the entire volume of the tumor from the surrounding healthy structures. To prevent the tumor from growing back, the surgical team must also remove the coccyx and the attached portion of the skin, extracting. Once the skeletal anchors are cleared, the team shifts to the front of the mass for the anterior dissection. This spatial map highlights the operation's most dangerous phase, working against the outer rectal wall, a single drastic digestive injury. Sometimes an abnormal fistulous connection links the tumor to the rectum. This tract must be excised and meticulous segments gone, surgeon's dead space left behind before closing the skin. A final pressure bandage is applied to surgeon while it heals. Surviving the excision depends on this millimeter navigation around the digestive tract, transforming a massive anatomical hazard into a safely closed system. While the neonatal teratoma years, the post-anal dermoid. Geography dictates the danger here. On the left is the outward swelling of the teratoma. On the right, the dermoid is in the same region but is tucked into the hollow curve of the sacrum, behind the anal canal and rectum. Because it is shielded by the bone and tucked behind the digestive tract, the cyst can sit dormant for decades, causing no symptoms and remaining unnoticed into adult life. Eventually, the cyst may expand. Because it is in the narrow space between the bone and the rectum, its growth often first manifests as difficulty in defecation. If the cyst becomes infected, physical consequences are severe. The infection carves a sinus tract, a tunnel from the hollow of the sacrum all the way to the exterior skin. The cyst sits directly against the rectal wall. A physician can feel the mass while it is still hidden behind the bone. Of our earliest development possess immense power. Managing them requires either immediate neonatal to uncover what stays in the dark corners of human anatomy.
Imagine the pelvis in lifelike 3D. zoom past the anal canal into the postanal space, where a smooth encapsulated cyst sits behind the anus. Labels appear: anal canal, levator ani muscles, and the coccyx. Inside, keratinous, hair-like, sebaceous debris fills a congenital pocket, ectodermal tissue trapped during embryology. After years, the cyst slowly enlarges. You can see the soft tissues bulge, swelling when sitting, aching pain, and sometimes recurrent infection. If drainage develops,
Deep within the humerus, a highly sensitive crossroads. The anorectal region is a dense network of nerve endings and muscle. Social stigma often leads patients to minimize or withhold details about symptoms in this area, pathologies, ranging from minor internal structural ruptures or occult carcinomas. To understand the diagnostic challenges of this region, we will examine 3 distinct conditions: acute physical trauma, subacute mucosal inflammation, and chronic intractable irritation, because different suspicion to distinguish between a temporary nuisance and a life emergency. Acute trauma to the rectum and anal canal represents the most immediate threat in this region. These injuries often result from severe high-impact falls, penetrating wounds, or complications during medical procedures, like enema administration. Is intraperitoneal, meaning it has occurred above the pelvic floor, or extraperitoneal, occurring below it. An intraperitoneal rupture allows waste to breach the sterile abdominal cavity, risking sepsis. Management requires an emergency laparotomy to suture the perforation and clear contaminants. To facilitate, a protective colostomy routes waste through the abdominal wall, bypassing the injured tissue entirely. These physical injuries require rapid mechanical intervention and waste diversion to prevent lethal complications from systemic poisoning. Moving from structural trauma, we encounter proctitis, an inflammatory condition of the rectal mucosa that carries its own set of biological risks. Proctitis is characterized by tenesmus, an intense, painful, and often unproductive urge to defecate. Instead of stool, the patient may pass inflammation. The exam typically reveals a swollen, reddened mucosa accompanied by small ulcers. Clinicians utilize cultures and smears to identify the specific pathogen responsible. Potential causes include dysentery, gonococcal infection, or even secondary tuberculosis. During the examination, biopsies are taken from any ulcerated tissue. This is a critical step to ensure that a localized inflammatory mass is not actually a hidden carcinoma. Effective treatment of proctitis is dependent on identifying the microscopic origin of the inflammation. The final stage of the spectrum is pruritus ani, an intractable and relentless itching in the perianal region. While often dismissed as a hygiene issue, chronic itching frequently signals an underlying systemic or surgical pathology. This diagnostic tree illustrates the symptom's clinical breadth. Systemic conditions like diabetes or are evaluated. The surgical branch reveals severe possibilities, where itching is the primary symptom for malignancies. Resolution requires treating the specific disease at the root. Pruritus ani demonstrates how a single, persistent symptom can serve as the clinical endpoint for a wide array of disparate and sometimes life-threatening diseases. Our analysis has spanned from urgent surgical repair of a ruptured abdomen, identification of microscopic pathogens, and the screening of occult melanomas. The anal-rectal region demands a wide range of clinical expertise, integrating trauma surgery, infectious disease, and oncology. The lower gastrointestinal tract functions as a sensitive indicator for both localized injuries and broader systemic health. Overcoming social stigma is essential for early diagnosis. Embarrassment often prevents the investigation required to identify dangerous conditions. A professional medical evaluation is the only way to accurately distinguish a minor irritation from a condition that requires immediate, life-altering intervention.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
At the very base of human lies the sacrococcygeal region. In early development, this location acts as a biological crossroads. This area houses the primitive knot of totipotent cells. These specialized units possess the biological capacity to form every distinct tissue type in the human body, from rigid bone to soft muscle and skin. Under normal conditions, these cells complete their job dividing. But if these signals fail to terminate, the cells multiply into a disorganized growing mass. The result is a sacrococcygeal teratoma, seen here as a large swelling protruding from the lower back of a newborn. It is the most common tumor found in neonates. Because this mass originates from totipotent cells, it retains the ability to construct complex structures, sometimes growing rudimentary limbs like hands or feet deep inside the tissue. If left attached, the physical toll on the infant is severe. The massive growth causes ulceration, blocks the rectal canal, and risks secondary infections and malignant transformation. Immediate surgical excision is the way to stop the mass from obstructing the rectum or becoming fatal. This cross-section shows the cramped geography surgeons must navigate. The tumor is wedged tightly between the sacrum and coccyx in back and the rectum in front. Looking closely, the mass is firmly attached to the coccyx and occasionally anchors into the sacrum. Facing the risks of infection and malignancy, surgeons perform the excision as soon as the diagnosis is confirmed. The procedure starts with a longitudinal elliptical incision. Surgeons lift the skin and subcutaneous layers to expose the dense bulk of the mass underneath. From there, the team must separate the entire volume of the tumor from the surrounding healthy structures. To prevent the tumor from growing back, the surgical team must also remove the coccyx portion of the sacrum, extracting them along with the mass. Success requires dismantling the skeletal anchors. Once the skeletal anchors are cleared, the team shifts focus to the front of the mass for the anterior dissection. This spatial map highlights the operation's most dangerous phase. Working against the outer rectal wall links the tumor to the rectum. This tract must be excised and meticulously sutured closed. Executing this closure perfectly is vital, as it often spares the infant from needing a colostomy. With the tumor and skeletons gone, surgeons drain the dead space left behind before closing the skin. A final pressure bandage is applied to secure the region while it heals. Surviving the excision depends on this millimeter-perfect navigation around the digestive tract, transforming a massive anatomical hazard into a safely closed system. While the neonatal teratoma is massive and obvious, this same region hosts a variation that can remain hidden for years, the post-anal dermoid. Geography dictates the danger here. On the left is the outward swelling of the teratoma. On the right, the dermoid cyst sits in the same region but is tucked into the hollow curve of the sacrum, behind the anal canal and rectum. Because it is shielded by the bone and tucked behind the digestive tract, the cyst can sit dormant for decades, causing no symptoms and remaining unnoticed into adult life. Eventually, the cyst may explode. Because it is trapped in the narrow space between the bone and the rectum, its growth often first manifests as difficulty in defecation. If the cyst becomes infected, the physical consequences are severe. The infection carves a sinus tract, a tunnel of diseased tissue, from the hollow of the sacrum all the way to the exterior skin. Because the cyst sits directly against the rectal wall, a physician can detect the soft swelling through manual palpation during a physical rectal examination. This internal check is the only way to feel the mass while it is still hidden behind the bone. These remnants of our earliest development possess immense power. Managing them requires either immediate neonatal surgery or the clinical vigilance to uncover what stays hidden in the dark corners of human anatomy.
Imagine the pelvis in lifelike 3D. You zoom past the anal canal into the postanal space, where a smooth encapsulated cyst sits behind the anus. Labels appear: anal canal, levator ani muscles, and the coccyx. Inside, keratinous, hair-like, sebaceous debris fills a congenital pocket, ectodermal tissue trapped during embryonic development. Over months or years, the cyst slowly enlarges. You can see the soft tissues bulge, swelling when sitting, aching pain, and sometimes recurrent infection. If drainage develops, a tender shifts to MRI and CT, a well-circumscribed retroanal cystic lesion surrounding tissue. Finally, surgery, a posterior perianal approach, careful dissection, and removal of the intact cyst, no rupture. The wound heals. Complete surgical excision is curative and prevents recurrence.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
In clinical practice, the duodenojejunal flexure marks the precise anatomical border where the upper digestive tract ends as occult or hidden losses of as little as 10 milliliters of blood per day, requiring sensitive chemical stool tests to detect. Conversely, rapid, severe bleeding can destabilize a patient's circulation within minutes. In these cases, physicians must often administer 2 or more units of blood through just to achieve hemodynamic stability. Because the condition can escalate from a microscopic leak to a life-threatening hemorrhage, locating the exact point of vascular failure is the immediate priority for the medical team. Before deploying advanced scanners, the primary screening method is known as melena, indicates that the source is positioned higher in the tract, typically within the small intestine. If the output is dark red, it suggests the failure is located within the colon, specifically the ascending, transverse, descending, or sigmoid regions. This chart shows how the color of the blood correlates to the depth of the lesion. While dark red indicates a colonic source, bright red, if it spatters during defecation, points directly to the anal canal. Pain provides a further diagnostic filter. Conditions located above and lower external lesions, like fissures. This initial analysis narrows the search radius, but confirming the exact site of the leak requires direct visualization of the intestinal wall. The first technological step is to clear the bowel and deploy endoscopes. Using proctoscopy, sigmoidoscopy, or a full colonoscopy, doctors send a high-definition camera into the lower tract. This direct line of sight helps the medical team identify 95% of common local lesions, such as polyps, inflammatory colitis, or tumors. Once the bleeding source is visible, doctors can deploy electrocautery, laser ablation, or apply metallic hemoclips to mechanic the flow. However, a complication arises when the bowel is prepped and the colonoscopy appears completely normal, yet the patient continues to lose blood. When surface-level optics fail, the medical team shifts focus from the lining of the intestine to the circulatory system itself. To find hidden or intermittent moves to nuclear scintigraphy. In this procedure, a patient's red blood cells are tagged with a radioactive isotope and re-injected. Because these cells remain in the vessels for several hours, repeat scans can catch the moment an intermittent bleed restarts. It compares standard blood flow to the detection threshold of the scan. The technique is set for bleeds occurring at a slightly faster rate of 0 milliliters per minute. The team escalates to selective angiography. A catheter is threaded into the mesenteric arteries to inject contrast dye. On the X-ray, the site of the hemorrhage is revealed by the glowing dye escaping the vessel and pooling in the intestine. If anatomical scans find no localized leak, the medical team checks for systemic failures, such as liver failure or blood dyscrasias, which prevent proper clotting. By transitioning from cameras to isotopes and contrast dyes, the search moves from the surface of the tissue into the chemistry of the blood itself. Treatment protocols run on 2 simultaneous tracks, resuscitating the patient from shock through fluid replacement while executing a targeted strike on the bleeding site. The angiography used for diagnosis becomes the primary treatment tool. Radiologists can now inject embolic material, like tiny coils or particles, directly into the specific that is leaking. This chart shows the effectiveness of the embolization process. The procedure successfully stops the hemorrhage in 70. The efficiency of these protocols lies in their ability to transition from a diagnostic scan to a life-saving intervention within a single procedure. Despite these advancements, a small percentage of patients suffer from obscure bleeding that remains invisible to every scan and scan. When every diagnostic and interventional tool fails, the final therapeutic option is a blind subtotal colectomy, the surgical removal of most of the large intestine to stop the unidentified leak. The pathway to this decision involves an escalation from analyzing physical symptoms to the use of nuclear tracers and arterial embolization. What was once an untraceable and often fatal event is now managed as a solvable mechanical failure, corrected through a systematic hierarchy of medical technology.
After discussing lower GI bleeding, discuss anal tumors, benign and malignant.
The human anal canal is a complex crossroads of tissue types. This diagram highlights three distinct zones: the outer perianal region, the dentate line in the middle, and the transitional zone above it. Perianal region, baseline for these symptoms: condyloma acuminata, or anal warts. Driven by a highly infectious filterable virus, these present as soft, outward-growing papillary masses. The tissue underneath remains pliable, and the infection can range from a few isolated bumps to an extensive mass that physically occludes the canal. Because the virus remains localized to the surface, treatment for small warts is typically limited to clinicians apply a 25% podophyllin solution or bichloroacetic acid directly to the tissue to burn the growths away. When the masses become extensive, they require surgical excision. However, because the recurrence rate for these viral infections is 60%, surgery is often paired with immunotherapy, using an autogenous vaccine, to help the body prevent the warts from returning. While warts are benign, they share a nearly identical symptomatic profile with invasive cancers. Itching and bleeding are present in both, and visual inspection cannot always distinguish a viral growth from a malignancy. This makes thorough histological examination through multiple biopsies an absolute clinical necessity. The first point on the spectrum is basal cell carcinoma. Usually originating near the dentate line, these tumors are relatively low grade and rarely spread to the lymph nodes. If caught early, they can often be managed with localized irradiation, though larger masses require full surgical excision. This diagram maps the most common malignant threat: epidermoid carcinoma. Vectors below the dentate line show squamous cell carcinomas. Vectors above indicate transitional cell carcinomas. Presenting as a hardened ulcer, it invades downward into mucosal layers, causing persistent rectal bleeding. For small tumors that have not yet reached the muscular layer, a wide local excision is the standard approach. This requires the surgeon to remove the tumor along with a strict 2.5 centimeter margin, ensuring no cancerous cells remain at the edges. More advanced cases require an abdominoperineal resection, which involves the removal of the rectum and surrounding perineal tissue. If the cancer has spread to the inguinal nodes, surgeons must also perform a radical dissection of the groin to remove compromised glands. This 6-week timeline maps combined therapy for advanced cases. On day 1, patients begin a 3 block alongside intravenous mitomycin C. On days 28 and 31, heavy doses of 5-FU are administered, shrinking the tumor significantly before surgery 4 to 6 weeks later. Successful treatment of epidermoid carcinoma relies on this multidisciplinary orchestration. By using a precisely timed sequence of chemotherapy and radiation, clinicians can weaken the malignancy before the first incision is ever made. At the furthest end of the malignant spectrum is melanoma. These arise from the epidermoid lining and feature a high degree of systemic aggression. While relatively rare, the anal canal is the third most common site for these tumors, following the skin and the eyes. A significant diagnostic difficulty with these tumors is that the majority are lightly pigmented or contain no pigment at all. They lack the dark, recognizable features of a skin melanoma, effectively blending in with the surrounding tissue. Because of this lack of pigment, these tumors are frequently misidentified during a visual exam. They resemble epidermoid carcinomas, warts, or harmless thrombotic piles. This map illustrates how anal melanoma spreads systemically. It moves through rectal mucosal layers, using inferior mesenteric nodes to bypass local lymph defenses. Entering the bloodstream, it reaches the liver and lungs relatively early in the disease's progression. Unlike other anal tumors, melanoma is uniquely radioresistant and does not respond well to chemotherapy. Because these standard oncological tools are ineffective, surgeons to radical abdominoperineal resection to have any chance of stopping the spread. Since this tumor resists most chemical and radiological treatments, time is the critical factor. Any delay in diagnosis allows the cancer to move systemically, which is why the 5-year survival rate remains around 15%, even in specialized institutions. The spectrum of pathology in the anal canal is vast, ranging from localized with topical acids to aggressive melanomas that bypass local defenses. The core challenge for clinicians is that these biologically distinct conditions share the same early signs. Minor itching and bleeding are the universal indicators for both the benign and the lethal. The outcome for the patient depends entirely on which point of the spectrum is being treated. The response can range from a simple chemical application to a life-altering radical resection of the pelvic tissue. In the region, symptoms cannot be taken at face value. Early, aggressive diagnostics and multiple tissue biopsies form the only reliable way to distinguish a minor infection from a life-threatening malignancy.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
Nerves and blood vessels. When rectal cancer takes hold here, surgically removing it becomes one of the most anatomically unforgiving procedures in oncology. For decades, the medical gold standard has been the traditional open technique. This requires a large abdominal incision, giving the surgeon direct, manual access to physically separate the tumor from the surrounding healthy tissue. Today, surgeons have a modern alternative, laparoscopic surgery. Instead of a massive incision, use small camera ports and elongated instruments to perform the exact same removal minimally invasively. This creates a difficult choice for patients. You have to weigh the value of a less painful, immediate recovery against the guarantee of long-term cancer survival. To make sense of this choice, we have to look at mapping our two primary evaluation metrics, surgical trauma on the x-axis and oncological certainty, meaning curative clearance, on the y-axis. The traditional open surgery approach plots right here. It requires a severe physical toll on the body, but it delivers maximum clinical evidence that the cancer has been entirely removed. The laparoscopic approach plots here. It reduces trauma significantly, but it sits lower on the certainty scale as surgeons continue to evaluate whether its success rate truly matches the open technique. The immediate appeal of a less painful recovery is a powerful motivator. It can create a bias toward the newer technology, even when the underlying biology of the tumor may demand a more aggressive physical approach. To make the right decision, you have to strip away the marketing appeal of minimally invasive technology. You must understand the brutal biological trade-offs happening inside the operating room. Let's start with the physical mechanics. Open surgery utilizes a large incision so the surgeon can direct manual mobilization of the rectum. This access serves a strict biological objective. The surgeon must cleanly and totally remove the rectal mesocolon, along with all the associated lymph nodes where microscopic cancer cells hide. By maximizing direct visualization and tactile feedback, the surgeon secures an uncompromising, highly curative clearance of all compromised tissues. The trade-off is a massive trauma to the abdominal wall. Patients face significant postoperative pain and a long, arduous stay in the hospital to recover from the incision alone. Laparoscopic surgery changes the mechanical inputs. Surgeons deploy a stapler through small ports, allowing them to mobilize the bowel without opening the abdomen. The immediate outcome is highly appealing. By avoiding a large abdominal wound, physical trauma drops rapidly. Patients experience minimal pain and go home much sooner. But this table highlights the hidden flaw. When we compare the outcomes, the laparoscopic method yields a measurable reduction in the degrees. The first specific risk of this method is dissemination. Using pressurized gas and remote instruments can cause microscopic cancer cells to escape the primary site and scatter widely throughout the open peritoneal cavity. The second risk happens at the end of the procedure. As the cancerous specimen is pulled out through the narrow incisions, tumor cells can physically implant and take root directly at the surgical port sites. A faster discharge from the hospital loses all value if the surgical mechanism itself creates new pathways for the cancer to spread. Anastomosis, reconnecting the remaining pelvic colon so normal bowel function can resume. Hand suturing this connection deep inside a narrow, restrictive pelvic cavity is technically excruciating and prone to error. To bypass this difficulty, modern surgery utilizes the EEA circular stapling gun. This device automates the connection and is standard practice in both laparoscopic and low-open procedures. This schematic shows the device. The two ends of the bowel are pulled tightly over an anvil, and tiny metal staples deploy in a circular pattern to fuse the tissues together. But this exacts a hidden anatomical cost. The stapling mechanism physically crushes and removes an extra 8 millimeters of the remaining rectum. Surgeons must meticulously recalculate their distal clearance margin to account for this exact loss. Failing to account for those 8 millimeters risks leaving live cancer cells right behind the staple line. Because of these extreme margins, there is a strict mitigation protocol that must be before the bowel is divided, particularly when staplers or laparoscopy are involved. The surgeon must aggressively irrigate the remaining rectum and anal canal with strong tumoricidal agents, such as povidone iodine. This chemical wash acts as a localized failsafe. It actively hunts down and destroys any exfoliated, free-floating tumor cells in the surgical field before they can seed into the fresh, unforgiving chemical mitigation. Without it, the mechanics of failure. Laparoscopic surgery offers a clear reduction in postoperative pain and hospital time, but its long-term curative results are still being measured against the old standard. We can use this decision tree to determine which surgical pathway matches your priorities. Path A is the efficacy-first profile for cases where absolute oncological certainty is paramount. If your ultimate goal is maximum cancer clearance and your body can withstand a harsh recovery, traditional open resection remains the gold standard. Path B is the recovery-first profile, minimizing immediate surgical trauma. To consider Path B, the procedure must happen at an elite center that employs aggressive cell spilligation protocols. Here, you actively accept nuanced risks in exchange for a rapid return to baseline physical function. If you choose this route, you must ask your surgical team explicitly about their specific clearance rates and their exact chemical mitigation protocols. In the end, success in cancer surgery is measured by the total absence of residual cells, regardless of the technique used to reach them. Operating on rectal carcinoma means navigating the restricted space of the human pelvis. Surgeons must extract a lethal mass from a tightly packed area, while preserving the surrounding nerves and tissues that dictate a patient's daily quality of life. Historically, the baseline approach lacked that precision. Without highly tailored options, patients faced an abdominoperineal resection. A wide physical toll of that surgery presented a major problem. Frail or elderly patients often could not survive such a severe intervention. Furthermore, many patients suffered from emergency bowel obstructions long before a scheduled surgery could even take place. Contemporary treatment relies on a different approach. Modern care is no longer a blunt instrument. It is a personalized arsenal designed to solve specific physiological limits, tailoring the scale of the intervention to the patient's immediate capacity. To see how medical science defeats this disease today, we must examine 3 distinct clinical obstacles that surgeons encounter: a completely obstructed bowel, or is too elderly to withstand a radical excision. For acute blockages, surgeons use a targeted emergency solution called a self-expanding metal stent, or SEMS. They deploy this metallic cylindrical mesh directly into the large bowel, where it expands outward to push back blocking tissue and rapidly decompress the colon. This device plays a strategic role. By reopening the passageway, it prevents the immediate need to create an emergency stoma, buying the medical team critical time to resuscitate the patient and prepare them for a safer elective surgery later. Doctors do have to be selective about where they deploy them. The pressure from the stent carries a high risk of delayed perforation and severe pelvic abscesses. If the patient is physically vulnerable, surgeons bypass massive resections in favor of Hartmann's operation. Through an abdominal incision, the cancerous portion of the rectum and close off the remaining rectal stump with sutures. Because the lower remnant is closed off, the bowel is not rejoined. Instead, the proximal end of the colon is brought out through the abdominal wall to form a permanent colostomy for waste removal. Since life-saving pivot, it prioritizes the patient's immediate survival. The second obstacle shifts the focus to the tumor itself. Doctors need a way to make a large mass easier to extract, and they need a failsafe to ensure that cancer cells don't spread while the surgeon is handling the tissue. They solved the size problem preemptively with radiotherapy. Delivering 2,000 rads over 2 weeks directly to the site can physically shrink large cancers prior to any surgical cuts, making the final removal far less invasive. For smaller, well-differentiated, the energy delivery is even tighter. Doctors use intracavitary radiotherapy, channeling a highly concentrated dose of up to 15,000 rads directly to the tumor through a sigmoscope. This schematic shows how doctors secure the perimeter during the physical extraction. Adjuvant chemotherapy is infused directly into the portal vein, the main vascular gateway to the liver, during and immediately after the primary surgical operation. The chemical payload labeled here uses the most effective worldwide standard, a combination of the drug 5-fluorouracil, or 5-FU, and systemic folinic acid, known as leucovorin. Together, they neutralize outlier cells circulating in the blood. By combining targeted radiation beforehand with perioperative chemotherapy in the moment, the medical team prevents the physical manipulation of the tumor from causing new metastases. They trap the cancer, ensuring it cannot flee the surgical site. The final clinical obstacle arises when the disease has passed its local boundaries, invading adjacent organs or spreading throughout the patient's body. If the spread is strictly local, surgeons escalate to extensive operations. Depending on the patient's anatomy, this might mean performing a total cystectomy to remove the bladder in males, or a total hysterectomy alongside the rectal excision in females. The absolute maximum physical and pelvic evisceration, or Brunschwig's operation. Surgeons remove all pelvic viscera and lymph nodes entirely and establish a new urinary diversion for the patient. If the disease is disseminated, surgery alone cannot reach it. Doctors deploy immunotherapy, utilizing laboratory-engineered monoclonal antibodies designed to hunt down and destroy specific cell embryonic antigens. However, these biological agents can occasionally damage normal tissue. To safely compensate, oncologists combine them with interferon alpha 2A and autologous tumor vaccines, utilizing the patient's own cellular material to boost native immune defenses. When the cancer breaches its initial boundaries, treatment evolves from applying this customized problem-solving methodology to rectal carcinoma yields a distinct, measurable outcome for patients. This comparison illustrates the success metrics in specialized centers. Surgical resectability has reached 95%, while operative mortality dropped below 5%. It is a victory of coordination, using chemical, radiological, and surgical tools to address the specific biological limits of the individual.
If you found this video informative, please share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
We are looking at the abdominal phase of a combined anterior-posterior rectal resection. The primary challenge of this procedure is strictly spatial. To reach the rectum, surgeons must descend into the true pelvis. Strained space creates an immediate. The goal is to achieve aggressive oncological clearance by removing compromised vessels and nodes, while meticulously preserving the delicate urogenital infrastructure sitting just millimeters away. This diagram shows a 3D wireframe of the pelvic cavity. To safely extract the targeted tissue, the overarching objective is complete isolation through a strict sequence, securing surface access, gaining superior vascular control, executing multiplanar mobilization of the surrounding ligaments, and finally, dividing the distal base. Success in a rectal resection requires mastering this specific spatial logic before a single cut is made deep within the pelvis. The geometry of the procedure, with the operating table's foot buttocks, sits exactly at the table's edge. Here is a schematic showing the precise setup. Lloyd-Davies leg rests flex the hips to 30 degrees and knees to 45 degrees. The Trendelenburg tilt offers a mechanical advantage. Gravity pulls the small intestine upward, naturally clearing the pelvic basin for operation. With the basin cleared, access begins with a long right paramedian incision, running from the umbilicus down to 2 centimeters below the pubic crest. The remaining coils of the small intestine are manually packed off into the upper abdomen, securing the clearance created by the table's tilt. The left wall of the wound is then retracted. Surgeons initiate mobilization by dividing the adhesions connecting the sigmoid colon to the posterior abdominal wall. This sequence highlights a practical reality. The patient's physical setup artificially engineers the spatial clearance required for the deep pelvic dissection to follow. Next, the descending colon is identified and pulled firmly to the right. The peritoneum is incised along this exposed border, moving continuously from the splenic flexure down to the sigmoid colon. During this downward incision, the surgeon must explicitly identify and protect the left ureter and the left gonadal vessels lying directly.
This exposes the surgical field for the primary oncological decision of the abdominal phase, determining exactly where to ligate the inferior mesenteric artery, or IMA. The ligation level is dictated entirely by evaluating lymph nodes clustered along the inferior mesenteric artery. If clear, the IMA is ligatured just below its first branch, preserving upper blood flow. If involved, the artery must be tied flush with the aorta. From this point of vascular division, the peritoneal incision is carried vertically downward to reach the right side of the rectum. This line is then extended forward over the front of the rectum, meeting the earlier incision on the left side to complete the initial circumference. The precise level chosen for the IMA ligation dictates the balance of the entire procedure, calibrating the preservation of colonic blood flow against the necessity of maximum oncological clearance. With vascular control established, focus shifts to the posterior dissection plane. The rectum is lifted forward away from the front of the sacrum. Using gentle, blunt finger dissection is gradually freed posteriorly, sliding down the hollow of the sacrum until it reaches the sacrococcygeal joint. This specific joint serves as a rendezvous point. The abdominal surgeon works downward to meet the perineal operator, who is simultaneously working upward from below, having already excised the last piece of the coccyx. During this posterior sweep, the fascia of Waldeyer is carefully incised, keeping the cut slightly distanced from the rectum. The rectum is pushed backward into the newly empty hollow of the sacrum to expose the front structures. The objective here is strictly defined, locating the exact plane of cleavage that lies between the rectum and the base of the bladder. In male patients, the rectum must be meticulously separated from the seminal vesicles and prostate. Extreme care is required to identify the vas deferens and maintain a precise dissection boundary. In females, the cleavage plane safely separates the rectum from the posterior vaginal wall. Navigating these planes requires to ride a millimeter-thin boundary, separating the diseased bowel without inflicting permanent damage to the surrounding urogenital structures. Once the anterior and posterior planes are freed, the rectum is tethered to the pelvis to define the lower ends of both ureters and confirm their position relative to the ligaments. Surgeons rely on traction and countertraction. The rectum is drawn forcefully to one side, opposite lateral ligament under heavy stretch. With the tissue pulled taut, the ligament is secured and divided. Throughout this cut, the corresponding ureter is kept in direct, continuous view. This exact maneuver is then mirrored on the opposite side. The rectum is now fully mobilized, triggering the division phase. The surgeon divide the colon by observing the visually obvious ischemic areas created by the earlier ligation. The bowel is physically divided by placing it between heavy crushing clamps, cleanly severing the devascularized tissue. The divided distal end is immediately covered with a sterile glove, ensuring the tissue can be extracted. Relationship with the abdominal cavity is officially severed. The procedure then transitions to the handoff. The entire freed mass of the rectum and colon is passed downward, where the second surgical team extracts it entirely through the perineal wound. Back up, the abdominal surgeon is left looking at an empty pelvic basin, with the underlying pelvic floor muscles fully exposed. The final step is the reconstruction of the pelvic floor to permanently seal off the abdominal cavity from the perineum. The rest of the remaining peritoneum are picked up, mobilized, and carefully aligned. This schematic illustrates the closure. The peritoneal gap is sutured using individual sutures or a continuous catgut suture, pulling the tissue together like a zipper. Final confirmation is mandatory, ensuring both ureters remain intact and protected beneath this new seam. The success of the abdominal phase relies on two distinct pillars: decisive proximal vascular control at the main artery around the pelvic anatomy. By systematically clearing the surrounding architecture plane by plane, this methodical spatial isolation safely transforms a complex abdominal resection into a highly controlled perineal extraction. In an abdominoperineal resection, the perineal phase is where we safely detach and extract a tumor from the lower pelvis. Before making the first cut down below, we have to confirm a strict starting condition. The abdominal surgical team above must have entirely completed their internal exploration of the colon. With the abdominal work verified, the perineal surgeon takes their position, seated squarely at the end of the operating table. This phase requires operating in a highly confined space. The surgeon must carefully navigate past delicate, often obscured anatomical structures to free the lower bowel intact. To prevent field contamination during the dissection, a dry swab is inserted into the anal orifice. Notice in this cross-section how a stout purse string suture is introduced around the perimeter, cinching the anus closed. Next, the surgeon traces an elliptical incision around it, extending deliberately back to the middle of the sacrum. The surgeon deepens this posterior section until the scalpel is cleared from its attachments on both sides and cleanly disarticulated from the sacrum. Look at this anatomical map. At the disarticulation point lies the middle sacral artery, a high-risk zone requiring immediate ligation if injured. Once secured, the fascia of Waldeyer is incised. The surgeon inserts a finger through this opening, guiding them to the levator ani muscles. Navigating this posterior entry safely gives the surgeon the correct depth plane required to safely execute the rest of the procedure. Now that the posterior depth is set, attention shifts to the lateral sides of the goal here is to widen the resection margins. In this cross-section, watch as superficial fat layers are stripped away. Deepening the lateral incisions exposes the underlying cavities known as the ischiorectal fossae. Crossing these perpendicularly are the inferior rectal vessels, representing a major vascular threat. The surgical team must carefully isolate and secure these specific vessels before cutting any deeper into the lateral tissues. Meticulous lateral vascular control keeps the field clear of hemorrhage. A bloodless field is an absolute requirement for the highly delicate anterior dissection that comes next. Moving to the front of the resection, the surgeon insinuates a finger on the upper surface of the levator ani muscle to act as a physical barrier. Using scissors, they divide the muscle on both sides. The shields the deep tissues, ensuring a sufficient margin remains attached to the rectum. The incision is deepened anteriorly, dividing the superficial and deep transverse perineal muscles, followed by the puba rectalis. This sequence exposes the most critical danger zone, the urethral bulb, sitting immediately adjacent to the resection plane. To protect it, the surgeon uses blunt gauze dissection, gently pushing the bulb forward and entirely out of the danger zone. The surgeon must clearly define the borders of the prostate gland before initiating further cuts. Once the urethralis muscle, tethering the rectum to the urethra, is severed, safely detaching the rectum anteriorly. Freeing the rectum while preserving the entire urethroprostatic complex marks the completion of the anterior dissection. Now, the perineal and abdominal dissection planes meet. The tissues part, uniting the two working fields and creating a continuous open pathway through the pelvis. The entire intact specimen, comprising the anal canal, rectum, and lower colon, is carefully drawn downward and delivered out through the perineal wound. With the specimen removed, the surgeon checks the newly emptied pelvic cavity, ligating any remaining vessels to ensure absolute hemostasis. Looking at this cross-section of the empty cavity, the surgeon places deep suction drainage. If localized oozing persists, a corrugated rubber sheet drain is added alongside it to ensure cellular debris has a clear exit path. Seamless extraction combined with rigorous multi-level drainage mechanics prevents dead space hematomas and guarantees a clean environment for tissue repair. With the perineal wound securely closed and the abdominal colostomy fashioned above, the surgical operation is complete. Immediate postoperative care requires raising the foot of the patient's bed. This mechanical adjustment safely relieves resting pressure on the newly reconstructed fragile pelvic floor. This removal of the hardware. The corrugated rubber drain is pulled after 48 hours. The section drainage is continued for another 1 to 2 days, and the urethral catheter remains in place for exactly 5 days. The perineal wound itself heals from the inside out via granulation tissue. The pelvic floor slowly fills in over a minimum of 4 weeks. By strictly adhering to these precise anatomical landmarks and managed postoperative timelines, surgeons
Like to see next and subscribe videos.
Like cancers anywhere in the body, the primary curative treatment available for carcinoma of the rectum is radical surgical resection. The objective is the complete physical eradication of the tumor, its surrounding tissue sheath, and all regional lymph nodes. To achieve this, the surgical team must map the exact location of the growth, select the appropriate approach based on spatial constraints, and execute
synchronized abdominal perineal resection, or APR. Before making a single incision, the colon and rectum must be completely devoid of fecal matter and bacteria. This requires mechanical cleansing through purgatives or whole gut irrigation, correcting any electrolyte imbalances, and placing an indwelling catheter into the bladder. Exactly 1 hour prior to surgery, the patient receives a precise prophylactic dose of antibiotics active against both aerobic and anaerobic organisms, typically 750 milligrams of cefuroxime and 500 milligrams of metronidazole. Failing to secure these preparatory conditions compromises the sterile field. If the bowel is loaded and active bacteria remain, the risk of tissue contamination guarantees surgical failure before the operation even begins. As a 3D model of the rectum, to determine the correct surgical intervention, the surgeon measures the exact distance of the tumor's lower margin from the anal verge. If in the proximal third, extending from 11 to 15 centimeters above the anus, it can usually be removed via a low anterior resection. The severed ends are reconnected through primary anastomosis, which conserves the natural sphincter mechanism. There is a clinical caveat for young patients. When proximal tumors grow rapidly in young subjects, a surgeon will often bypass the anterior resection and perform a full abdominoperineal resection to prevent aggressive recurrence. Moving down to the middle third, conserving the sphincter becomes highly difficult. The narrow space deep in the pelvis makes it hard to secure the necessary 5 centimeters of normal tissue below the tumor and still have physical room to reattach the bowel. To solve this constraint, surgeons use an EEA stapler. This instrument creates an inverting end-to-end anastomosis, making it technically possible to resect mid-rectal carcinomas down to their distal limit and safely restore tissue continuity. Finally, if the tumor is third, below 7 centimeters, it is entirely extraperitoneal. At this depth, an abdominoperineal resection is the mandatory, unavoidable intervention. The physical location of the tumor on this anatomical ruler decides the procedure. These exact measurements determine whether the patient retains sphincter preservation or requires a permanent colostomy. Exactly 5 centimeters of normal tissue above and below the growth. To ensure all involved regional lymph nodes are removed, the surgical team traces the arterial supply upward to the inferior mesenteric artery, or IMA, finding its exact origin point on the aorta. If the main nodes are involved, the artery receives a flush ligation right at the aorta. Because this requires excessive resection of the bowel, surgeons prefer to ligate the IMA slightly lower, below the origin of its first 1 or 2 branches, provided the nodes allow it. This upstream arterial supply dictates the boundaries of the excision. By dividing the main blood vessels, the surgeon captures and removes all potentially malignant lymphatic drainage pathways tied to those arteries. In 1910, surgeon Ernest Miles advocated the radical abdominoperineal resection as a sequential procedure, where one surgeon finished the abdominal part before moving to the lower end of the table. By 1938, Lloyd Davies updated this to a synchronized operation. This synchronized setup necessitates a coordinated arrangement. 2 surgeons work simultaneously on the same patient. This setup dramatically saves operative time, far less systemic shock to the patient. The abdominal surgeon's primary objective is top half of the surgical field. They isolate and remove 3/4 of the pelvic colon, along with its mesocolon, freeing the entire rectum and its surrounding fascia down to the pelvic floor. Breaking these upper attachments mobilizes the entire diseased block from above. Disconnecting the superior structures clears the path, making the final extraction possible from below. Working at the same time, the perineal surgeon starts from the lower end of the table. Their first step is making a wide incision through the skin. This diagram isolates the pelvic floor musculature. The perineal surgeon performs a deep excision to capture the lower structures, specifically targeting the external sphincter muscle and the entire anal canal. Next, they remove the adjoining sections of the pelvic floor and peritoneum. This physical breach connects the lower surgical field directly to the upper dissection plane established by the abdominal surgeon. With the superior and inferior attachments broken, the unified tissue block containing the rectum, fascia, lymph nodes, and anal canal can be extracted in one piece. The result of this synchronized teamwork is a perfectly cleared pelvic is removed, achieving a complete, radical eradication of the localized tumor field. Because this distal operation requires removing the anal canal, the patient experiences a permanent total loss of the sphincter mechanism. To restore waste elimination, the upper end of the divided colon is drawn through the abdominal wall, establishing at exactly 6 and 12 hours post-operation. By combining precise spatial lapping with synchronized surgical execution, systematically removes the carcinoma, clearing the way for the patient's long-term recovery.
Because there's no natural opening left for stool to leave the body, a new route is created, a permanent colostomy. How is it made? 1. The surgeon gently mobilizes the remaining healthy colon. 2. A small circular opening is created on the abdomen, usually on the left lower side. 3. The healthy colon end is brought through carefully, without twisting or pulling. It is stitched to the skin, forming a stoma. From then on, stool passes out through the stoma into an ostomy bag. You can live normally with it and feel okay. Thinking a permanent colostomy means your life is over? Usually it isn't. After surgery, most people adapt surprisingly well. Modern colostomy bags are discreet, lightweight, and waterproof, built to help prevent leaks and reduce odor, so you can breathe easier. You can go back to work, travel, exercise, and even swim. Social plans still happen. You just carry a small, reliable routine with you. The key is proper stoma care. Your specialist stoma nurse will show you how to empty and replace the appliance and how to look after the skin around your stoma. You'll learn what normal looks like and how to spot problems early before they become bigger issues. With practice, colostomy care is a simple daily step. Nothing scary, just manageable. You'll get used to choosing the right fit, checking the seal, and keeping supplies handy. Over time, confidence grows and daily life feels like yours again truly too. Like any surgery, a permanent complications, but most are manageable. First, watch your skin. If stool leaks onto the area around the stoma, it can get irritated, sore, or red. Next, be aware of a peristomal hernia. You might notice a bulge around the stoma, especially when you cough or lift. Other issues can happen too. The bowel can prolapse outward, or rarely, you may feel like output is temporarily blocked. The good news? Prevention matters. Proper surgical technique, correctly fitting appliances, careful skincare, and regular check-ins with your surgical and stoma care team make a big difference. If you ever have doubts about fit, wear time, or your team can adjust supplies quickly before irritation grows too. Don't wait if something changes. Early recognition and treatment can stop minor problems from becoming serious. Stay steady, stay informed, and get help promptly. After rectal cancer surgery, a permanent colostomy can feel like a shock, but it isn't just a procedure. It's a life-saving reconstruction that helps remove cancer and protect your future. When you heal, many people bounce back with real independence at your own pace. Your day-to-day rhythm can return: meals, walks, work, and time with family, often with an excellent quality of life. Long-term well-being comes from simple habits: eat for strength, stay hydrated, move regularly, and keep routine medical follow-ups. Think of it as teamwork between support groups and specialist stoma nurses share practice or questions and help you build confidence step by step. The goal is clear: complete cancer removal, then a return to an active, fulfilling life. A permanent colostomy isn't the end of normal living. It's the beginning of recovery.
If you found this video informative, please like and share. Comment what you would like to see next.
If a patient is diagnosed with carcinoma of the rectum, clinical protocols dictate a strict reality. Radical resection of the affected anatomy is the only curative treatment available. A radical excision requires removing the rectum and its sheath, securing exactly 5 centimeters of healthy tissue above and below the visible growth. The surgeon must also completely excise all regional lymph nodes along the rectal wall and immediate vascular network. Executing this massive tissue and lymphatic clearance presents a severe mechanical challenge. The surgeon must remove this entire geometry from the deep pelvis, a rigid, heavily crowded by surrounding organs, nerves, and major vessels. Because the pelvic floor acts as an absolute physical boundary, the exact vertical coordinate of the tumor dictates the outcome of the surgery. That height represents a brutal calculus. It determines whether the surgeon has the physical space to save the patient's functional sphincter mechanism, or if they must sacrifice it entirely to achieve a cure. To guarantee the removal of the main regional lymph nodes, the surgeon has to map the lymphatic drainage back to its source. For the rectum, this requires targeting the proximal blood supply, the inferior mesenteric artery, or IMA. This close-up shows the abdominal aorta and IMA origin. Performing a flush ligation, tying the artery exactly at its branch, maximizes lymph node harvest. However, this high ligation forces excessive bowel resection. To preserve bowel, surgeons shift the ligation below the first arterial branches. While mapping the vascular supply addresses the outer boundaries of the resection, the colon's internal environment poses a separate immediate threat to the patient. The colon and rectum must be totally devoid of fecal matter and bacteria before the procedure. Clinical teams achieve this through aerobic and anaerobic organisms. Protocol requires 750 milligrams of cefuroxime combined with 500 milligrams of metronidazole. This timeline charts the exact dosing schedule. The initial dose is administered exactly 1 hour before the first incision. 2 subsequent doses of the identical drugs are administered at the 6-hour and 12-hour marks following the operation. Establishing this highly controlled, sterile, and ischemia-free environment is an absolute prerequisite. Only after these protocols are complete can the surgeon safely begin navigating the high-stakes spatial limits of the pelvic floor. To systematically determine which surgical technique is required, surgeons divide the rectum into 3 vertical zones. The pelvic map highlights the proximal third, extending from the sigmoid colon junction down to 11 centimeters above the anus. If a carcinoma develops here, the required 5 centimeter downward clearance margin projects safely within the cavity, terminating well before the anal sphincter complex. Diseased segment and immediately suture the healthy colon to the remaining lower rectum, conserving the patient's sphincter mechanism. To protect this newly constructed joint, or anastomosis, while it heals, the surgeon may create a temporary defunctioning colorectal up the bowel, diverting waste away from the surgical site. There is a clinical exception to this rule. In young patients with aggressively rapid tumor growth, surgeons will often bypass the anterior resection. To prevent a high probability of recurrence, they will opt for a more extensive abdominoperineal resection. A proximal third tumor represents the ideal surgical scenario. The physical height of the lesion affords the spatial clearance necessary to guarantee oncological safety without permanently destroying the patient's fecal continence. Constraints tighten in the middle third, extending from 11 centimeters down to the anterior peritoneal reflection, 6 to 8 centimeters above the anus. When a tumor drops here, the mandatory 5 centimeter clearance margin projects downward, colliding directly with the anal sphincter mechanism. If a surgeon attempts a standard anterior resection here, the procedure invariably results in cancer recurrence. Taking the required 5 centimeters of healthy tissue leaves virtually no physical space to safely suture the bowel back together deep in the pelvis. The safest, most definitive method to clear a midrectal tumor is an abdominoperineal resection. This completely sacrifices the sphincter and requires the creation of a permanent colostomy. To avoid a permanent colostomy, surgeons developed alternatives, beginning with the abdominoperineal pull-through operation. Instead of attempting to suture inside the restrictive pelvic cavity, the surgeon draws the proximal colon down through the pelvis. They then suture it to an inverted anorectal stump entirely outside of the anal canal. While this solves the problem of pelvic access, it carries a severe gain fecal continence. To solve this seemingly impossible biological bottleneck, medical engineering intervened with a highly specialized, precise surgical tool, the EEA stapler. The instrument fires a circular, inverted ring of titanium staples, seamlessly connecting the proximal colon to the distal limit of the rectum. It securely bridges the gap, creating an end-to-end anastomosis in a physical space too tight for manual suturing. The EEA stapler bypasses a biological bottleneck with mechanical precision. It allows surgeons to push mid-rectal tumor absolute distal limits while still preserving the patient's anatomical continuity. The final anatomical zone is the distal third of the rectum. This section sits entirely outside the peritoneum and encompasses the anal canal itself. At this step, the 5 centimeter rule fails completely. The required margin engulfs the entire anal canal and the surrounding perianal skin, leaving absolutely zero room for sphincter preservation. For extreme distal tumors, total extirpation is mandatory. The surgeon must perform abdominal perineal resection, or a perineo-abdominal resection. When William Miles formalized the abdominal perineal resection in 1910, it was a sequential operation. One surgeon would operate on the abdomen, then physically move to the lower end of the table to perform the perineal extraction. This changed in 1938 when Oswald Willard Davies introduced the synchronized approach. This illustration details the synchronized setup. Two completely separate surgical teams operate on the same patient at the exact same time. One team works downward, while the other team simultaneously dissects upward from the perineum. Operating in parallel provides two massive medical advantages. It drastically reduces the total operative time under anesthesia, which directly correlates to a significant decrease in physiological shock to the patient. When the tumor's location dictates that all anatomical limits must be breached, preservation is no longer an option. Primary weapon to mitigate the severe trauma of a total pelvic clearance. The ultimate objective of a synchronized abdominoperineal resection is to extract an immense block of tissue, ensuring the bowel, the tumor, and the entire lymphatic drainage basin are removed as a single unit. Deconstructing this 3D model reveals the sheer scale of the excision. The lower resection includes the anal canal, the external sphincter muscle, and a wide margin of perianal skin. Above that, the entire rectum is removed, along with its surrounding fascia and the pararectal lymph nodes. The upper structures include the adjoining pelvic floor and perineum. Finally, the procedure removes 3 full quarters of the pelvic colon, taking the mesocolic lymph nodes along with it. Every structure removed in this block is dictated by strict clinical geometry. Radical rectal surgery relies entirely on understanding these spatial rules, accepting the rigid limits of the human anatomy. The choice of operation is an unyielding calculus. It forces the surgeon to balance the exact depth required to achieve total oncological clearance with the physical possibility of preserving the architecture of the human pelvis.
Rectal cancer management starts with clarity. You begin with a gentle 3D look where the rectum sits, softly outlined so you understand the target. Next, MRI, endoscopic ultrasound, and CT come together to show how far the tumor has spread. The holographic cue reads TNM staging. Think of it as a map for treatment decisions. In a multidisciplinary tumor board, a surgeon, oncologist, and radiologist review the scan together, balancing cancer control with quality of life. For locally advanced cases, you may see neoadjuvant chemoradiation first, shrinking the tumor before surgery. Then the gold standard approach, total mesorectal excision, removes the cancer with careful precision while protecting nearby structures. After surgery, adjuvant therapy can follow and surveillance starts. Blood tests like CEA, colonoscopy, and periodic CT scans. With early detection and precise treatment, outcomes keep improving year by year. You're not alone. Your team guides you.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
Here, we zoom in to reveal a tumor in the lower
Within the pelvic cavity, at the terminus of the gastrointestinal tract, a slow, silent architectural disruption can begin. Long before a patient notices a single symptom, a rectal carcinoma is already establishing its presence. This is predominantly a disease of older. When it does occur in younger patients, the biological behavior of the tumor tends to be much more aggressive, resulting in a noticeably poorer prognosis. Compounding this threat is the reality of human behavior. Because the early signs are easily rationalized, patients disease for up to 6 months before finally seeking medical evaluation. To understand those signs, we have to look at exactly where the disease starts, the mucosal layer lining the inside of the rectal wall. Grasping this precise point of origin, paired with the patient's age demographic, provides the required context to interpret every clinical symptom that follows. This diagram illustrates a cross-section of healthy rectal mucosa. Notice the neat, uniform rows of columnar cells, arranged in an orderly, stable architecture designed to secrete mucus and facilitate the passage of waste. The pathology begins. They break formation, replicating rapidly, and piling up to creation on the mucosal surface.
Left unchecked, this microscopic dysplasia advances into a macroscopic malignant adenocarcinoma. The mass expands both outward into the lumen and downward, forming chaotic gland-like structures that breach the initial boundary of the mucosa. The way this tumor physically grows, the specific shape it takes, and the direction it invades is highly systematic. Its resulting gross morphology, meaning its ultimate shape and size within the rectum, direct clinical symptoms the patient will eventually experience. Because a rectal tumor is a tangible structural anomaly within a functional tube, we can effectively reverse engineer a patient's clinical presentation simply by understanding the tumor's physical shape. The most constant and earliest warning sign reported by patients is bleeding per rectum. While easily mistaken for an uncomplicated internal pile, careful history reveals a distinct pattern. Malignant bleeding is usually slight, painless, and often mixed with mucus, typically occurring alongside or at the end of defecation. This diagram shows an annular carcinoma at the narrow rectosigmoid junction, growing inward to constrict the central passage. As the lumen narrows, solid stool backs up against the stricture, presenting clinically as steadily increasing constriction. Patients often respond by self-medicating with escalating doses of laxatives. This forces liquid stool past the stricture, triggering a bradycardia, which inevitably reverts back to constipation once the laxatives are stopped. Alternating bowel habits serve as a direct mechanical signature of a stricturing annular tumor obstructing the colon. A completely different presentation, proliferative or cauliflower-type growth. This animation shows the rectal, the wider lower half of the rectum. Here, the tumor doesn't form, but instead bulges outward from one side of the wall as a large irregular mass. This morphology causes a symptom known as spurious diarrhea or tenesmus. The patient feels an urgent need for blood-stained mucus. Mimics formed feces, constantly tricking the evacuation reflexes. Pain is absent early on, becoming a factor only when the tumor breaches the outer boundary, the fascia propria, and invades surrounding structures. If the growth extends backward to invade the sacral plexus, the patient will complain of severe pain radiating down the leg, presenting clinically as sciatica.
Escalating constipation points to a high stricture, while early morning lower bulky mass, revealing shape and location before imaging even begins. Despite the availability of advanced imaging technology, the most critical step in physical diagnosis remains the simple digital rectal examination. An astounding 90% of all rectal carcinomas are situated low enough to be felt directly by a clinician's finger. The clinician identifies a distinct indurated feel, a hardened, irregular tactile resistance that indicates tissue. For higher growths, bimanual palpation, placing one finger in the rectum while pressing down on the abdomen, allows the clinician to gauge mass size and mobility. The examination concludes with an immediate visual check. Inspecting the withdrawn gloved finger for smeared mucus and blood provides highly reliable evidence. If present, cancer is almost certain. This is why every case of even a slight rectal problem mandates this physical check to rule out malignancy. Following physical detection, proctosigmoidoscopy and colonoscopy are required. These provide direct visualization of the tumor and exclude the presence of multiple adenomatous polyps or synchronous carcinomas higher up in the colon. Once the target is acquired visually, this schematic illustrates the strict biopsy protocol. Tissue samples must be extracted precisely from two locations, the outer edge of the tumor, dead center of the mass. This dual sampling ensures an accurate analysis. The expanding edge yields actively dividing malignant cells, while the center often contains dead necrotic tissue. This microscopic slide view demonstrates what the pathologist is looking for. Hyperchromatic, enlarged cells forming chaotic glandular patterns provide the definitive confirmation of an adenocarcinoma. While the physical exam maps gross anatomy, endoscopic visualization and histological tissue sampling confirm its malignant identity and measure its biological aggression. Knowing a malignant tumor exists and knowing its grade is still not enough for a surgical plan. The clinician must now map its exact depth of local invasion into the surrounding tissue. This brings us to endorectal ultrasonography. As seen in this animation, an endoprobe is passed into the rectum,
A water balloon is inflated for acoustic coupling, and a 360-degree sonar scan maps the 4 distinct concentric layers of the rectal wall. ERUS operates as a highly accurate preoperative staging tool by revealing exactly which of these mucosal and muscular layers the cancer has successfully breached. The scan reaches beyond a wall as well. It identifies metastatic involvement in the mesorectal lymph nodes, visualizing them as dark, poor oval anomalies. Finding more than 3 of these involved nodes signals a significantly poorer prognosis. While MRI and CT scans are standard, ERUS is superior for assessing these specific wall layers. However, MRI remains the better tool for evaluating broader extension into the mesorectal fascia and adjacent organs. The final requirement is systemic staging using CT or PET-CT. What we are checking for: distant metastases, most commonly lodging in the liver or lungs, which account for late-stage symptoms like abdominal distension or jaundice. The effective management of rectal carcinoma relies entirely on this disciplined chain of logic. It requires tracking the tumor from a microscopic mucosal origin, decoding the mechanics of its physical symptoms, proving its existence digitally, and executing multimodal imaging to map both its local depth and its systemic.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
In your animation, the story starts with clues: blood and stool, change in bowel habits, narrow stools, abdominal or pelvic pain, weight loss, fatigue, or anemia. When these signs show up, clinicians don't assume the worst, take them seriously. First, they ask about timing, family history, and medications, then do a digital rectal exam to feel for abnormalities. Next comes colonoscopy with biopsy, where a small camera checks the rectum and a tissue sample confirms what's happening. After confirmation, imaging like MRI of the pelvis and CT of the chest and abdomen help tumor and lymph nodes, guiding treatment planning. Finally, lab tests measure blood counts and health factors. The key message: symptoms aren't a death, but they're a clear call to get checked early. That's how the 3D journey moves from first symptoms to confirmation and staging, so doctors can choose the next step.
Clinical features of rectal carcinoma. The rectum is the final segment of the large intestine. Here, we zoom in to reveal a tumor in the lower rectum. Streaks of bright red blood to appear. Rectal bleeding is the most common symptom. As the tumor grows, it narrows the rectal passage. This causes the stool to become pencil thin. Other changes include constipation, diarrhea, and a frequent urge to pass stool.
The human rectum is the disease typically begins as precancerous polyps, or villus papillomas, growing slowly without triggering any systemic alarms. Looking at these gross specimens, form into once malignant. Depending on where they grow along the tract, distinct physical shapes, like the dense proliferative masses in the ampulla or tight constricting rings of an annular variety. While these visible shapes reflect the outward symptoms of the disease, the internal engine is a microscopic rebellion happening deep within the tissue layers. When a pathologist examines tissue biopsies under a microscope, they identify the primary culprit responsible for most of these tumors, the columnar cell adenoma. We use Broder's classification to grade the threat level. A well-differentiated tumor closely resembles normal, healthy tissue, growing at a slow pace. Cells have completely lost their original structure, multiplying rapidly and aggressively. In a small size, a specific anomaly called colloid carcinoma emerges. The cancer cells produce excess mucus, which physically pushes the nucleus to the outer edge of the cell, creating a distinct signet ring appearance that signals a highly malignant, fast-moving threat. This microscopic grade acts as the tumor's engine, dictating the sheer speed and violence of its impending outward expansion into the surrounding anatomy. This animated cross-section expanding circumferentially. It takes 6 months to cover 1/4 of the wall and 2 years for a full ring. Radially, it breaches the muscular, invades the prostate and bladder in men, the vagina and uterus in women, or even the sacral nerves running behind the rectum. Because the tumor navigates these fixed anatomical layers in sequence, its local is essentially a slow, highly predictable, and entirely measurable destruction of boundaries. While the tumor slowly pushes outward, a secondary threat activates. The moment the cancer involves the muscular layer of the rectum, it gains access to the body's hidden lymphatic drainage system. This maps those hidden highways. Tumors high in the rectum escape vertically to main nodes. Middle tumors spread laterally along the middle rectal vein. Conversely, tumors near the anal orifice drain downward, directly invading the inguinal nodes to spread further into the body. The final and most dangerous invasion occurs when the tumor forcefully breaks into the blood supply. This venous spread typically happens late in the disease's life cycle, though rapidly growing anaplastic tumors can force their way in much earlier. Once inside the bloodstream, the inferior mesenteric acts as a direct, lethal conduit, carrying metastatic cancer cells straight to the liver. Tumors situated unusually high in the rectum face an additional Neonates networks. The cancer escapes its physical confines. A localized anatomical siege becomes a systemic, whole-body crisis. To effectively fight a cancer that expands in 3 dimensions, oncologists must translate this biological chaos into a standardized medical map. They use spatial metrics like Duke's classification, which categorizes the tumor based on a few physical thresholds. Is the growth contained within the rectal wall? Has it extended beyond the wall? Or has it reached the regional resolution coordinate system? We look to this TNM matrix. The T variable tracks exact depth of invasion. T1 marks superficial coats, T2 hits the muscular wall, and T4 breaches boundaries. The N determining if regional nodes are compromised. Finally, the M metric confirms distant metastases, like in the liver. Clinical staging is essentially 3-dimensional cartography. It provides the exact coordinates of the cancer's invasion at a specific moment in time. A patient's ultimate prognosis depends entirely on the intersection of 2 data points: the clinical stage, mapping physical spread, and the histological grade, revealing the cellular engine driving it. Because of this interaction, a patient with a tumor detected in an early physical stage, but driven by an aggressive cell type, can face a worse prognosis than someone with a late-stage tumor that remains well-differentiated and slow-growing. By identifying both the precise speed of the cellular engine and the physical boundaries the tumor has breached, physicians can map its trajectory. Mastering this tree of invasion is the only way to accurately predict the tumor's next move and chart a definitive path to stop it.
Rectal carcinoma is primarily a disease of old age, but it has a built-in head start against doctors. On average, they harbor the disease for a full 6 months before ever stepping foot in a clinic. The delay happens because early rectal cancer doesn't present as a distinct. Instead, its clinical features mimic minor, everyday inconveniences. The earliest and most constant sign is bleeding during or right after defecation. It's painless, and it usually only leaves a slight spot on toilet tissue or underclothing. Because it mirrors the presentation of uncomplicated internal hemorrhoids, commonly known as internal piles, patients consistently misattribute the symptom to a benign cause. Soon after, the patient experiences an alteration in their bowel habits, a creeping increase in constipation. Rather than viewing this as a reason to consult a doctor, the typical patient chooses to self-medicate. They head to the pharmacy and start taking steadily increasing doses of over-the-counter laxatives to force their digestive system to keep moving. This self-medication creates a cycle. The high dose of laxatives eventually triggers a brief period of diarrhea. Thinking the problem is solved, the patient stops taking the medication, only for the severe constipation to immediately return. If the tumor is growing in the lower half of the rectum, it physically occupies the lower bowel, creating a constant, false sense of incomplete defecation. The patient feels a persistent need to open their bowels, resulting in frequent visits to the toilet. But instead of passing normal stool, they only pass gas along with a bloody, mucus-like slime. Clinically, this is known as spurious or false diarrhea. Alternatively, if a large cauliflower-like tumor forms in the middle section of the rectum, the ampulla, the patient will experience a specific presentation: early morning diarrhea. They are forced out of bed to rush to the toilet, passing large amounts of blood and mucus mixed directly into their stool. Notice what is missing from all of these early stages: pain. Severe symptoms like colicky abdominal pain from an obstruction, shooting sciatica down the leg, or jaundice and palpable liver lumps do not occur early. They only appear late in the disease with minor ailments, Doctors cannot wait for clarity. The moment a patient reports a recurring rectal issue, clinicians must initiate a high-speed diagnostic sequence to find the disease before those late-stage symptoms arrive. The first line of defense is purely physical, the digital rectal exam, or DRE. By simply examining the lower rectum with a gloved finger, a doctor can physically feel the typical indurated or hardened texture of a carcinoma. 90% of all rectal cancers can be detected this way. If the growth is located higher up, near the junction where the colon meets the rectum, doctors use bimanual. By placing one finger internally and applying pressure to the lower abdomen or through the vagina in female patients, the physician can trap the higher tumor between their hands to assess its size. Once a tactile anomaly is found, the investigation shifts to visual evidence. The clinician inserts a proctosigmoidoscope, a rigid, lighted tube, into the rectum to look directly at the surface of. Seeing the tumor isn't enough. They need a tissue sample.
Using the scope, the doctor takes biopsies from both the outer edge and the center of the mass. Examining these samples under a microscope reveals the histological grade, telling the medical team exactly how aggressively the cancer cells are behaving. Sometimes, cell spasms prevent the scope from navigating the intestine. When this happens, doctors deploy a barium enema X-ray to coat and visualize the lining of the bowel. Even when a lower tumor is successfully found, a full colonoscopy is still performed to hunt for secondary, hidden carcinomas further up the digestive tract. But at this point, the medical team faces a critical blind spot. Physical exams and surface cameras prove the tumor exists in the lumen of the bowel, but they cannot see the depth. They do not know how far the tumor has buried its roots into the layers of the rectal wall, leaving the true stage of the cancer unknown. Standard CT and MRI scans can tell if a tumor has completely broken the rectum, but they lack the resolution to see the microlayers of the intestinal wall. To pierce this blind spot, clinicians turn to endorectal ultrasonography, or ERUS. The setup is highly specialized. An ultrasound probe is passed through a sigmoscope until it sits just above the lesion. Once in position, a latex balloon wrapped around the probe is inflated with degassed water with the air removed so it won't distort the sound waves. This animated diagram illustrates how it works. The scope is slowly withdrawn, and the activated transducer inside the balloon emits 360-degree radar-like waves, scanning outward through the tissue. Watch the cross-section. ERUS maps the precise depth of local invasion, or fat, the tumor has burrowed into. As the sound waves travel even further out, ERUS identifies mesorectal lymph nodes that have been invaded by the cancer. These metastatic nodes show up clearly on the scan as dark, echo-pore oval shapes. Discovering these nodes triggers a specific prognostic calculation. If the scan reveals more than 3 involved nodes, or detects that the cancer has spread sideways into the lateral lymphatics, it signals a highly dangerous spread. The surgeon now knows they must perform a wide lateral clear resolution cross-sectional mapping tool. Specific spatial intelligence required to calculate a patient's odds of survival dashboard. By pulling all this data through the physical exam, the histological grade from the biopsy, and the depth map from the ultrasound, the surgeon assembles a detailed 3-dimensional profile of the threat. This staging directly dictates the treatment. If the data shows a locally advanced case, the surgeon will halt immediate operation. Instead, they will use primary radiotherapy to shrink the tumor before the scalpel ever touches the patient. This level of anatomical mapping gives the surgeon the confidence to perform sphincter-saving resections, preserving normal bowel function. And long after the surgery is done, ERUS is deployed again during follow-up visits, scanning the surgical site to hunt for asymptomatic local recurrences. Recovery starts reporting minor digestive changes, followed by a medical team using an escalating protocol to strip away the cancer's initial anonymity and provide life-saving clarity.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
Rectal carcinoid tumor typically remains in the submucous coat, the layer of tissue just beneath the rectal lining. Because the growth happens in this deeper layer, the mucous membrane directly over it remains completely intact. When viewed through an endoscope, it doesn't look like an aggressive mass.
It appears only as a small, plaque-like elevation on an otherwise healthy-looking wall. This camouflage is the first hurdle in diagnosis. The physical presentation of the tumor actively downplays the reality of what is developing below the surface. The tumor's behavior initially seems to match its unassuming outward appearance. The majority of these growths are slow in their progression. They are noted for being very late to metastasize or spread to other regions of the body. Usually, a small, localized anomaly that grows at a glacial pace might suggest a conservative approach, monitoring the growth rather than. Yet, medical guidelines for these tumors deviate from that logic, calling for immediate surgical excision even when the growth appears minor. The reason for this urgency is found in the clinical data regarding the risk of malignancy. To understand the threat level, compare the rectal variant to carcinoids in other parts of the digestive tract. It is consistently found to be more malignant than carcinoids of the appendix. This chart shows how the rectal variant sits between the less aggressive appendicular carcinoids and the more small intestine. This places the malignancy rate for the rectal variant at approximately 10%. A 1 in 10 chance of cancer in an anomaly that masks its growth changes the medical math. It shifts the protocol from observation to physical extraction. Because the threat is buried beneath an intact surface, surgeons use specialized localized techniques like endoscopic mucosal resection to with metallic surgical clips, shown in panel F. This physical unearthing is the only way to neutralize the 10% threat before it can exploit its hidden position to grow undetected. While effective, this localized endoscopic removal is primarily used for smaller, early-stage discoveries. If the tumor is not caught early, it can become more deeply entrenched in the surrounding anatomy. In these much more advanced clinical cases, the strict medical requirement shifts to a full excision of the rectum. The escalation from a small clip to a full excision illustrates the persistence of this specific tumor if left to develop. There is also the scenario where the tumor is discovered only after it has achieved a late-stage metastasis. In many other forms of cancer, systemic spread might lead a doctor to move away from aggressive local surgery. But here, the clinical directive is clear. Even in the presence of whether used for an early cure or to extend life in advanced stages, surgical removal remains the primary tool for managing the risk this hidden threat presents.
This cross-section illustrates the healthy anatomy of the human natal cleft. Visible layers include the epidermis, dermis, and subcutaneous tissue, vascular structures. The embedded hair now acts as a foreign body. The body initiates an inflammatory response, blood vessels to dilate. Trapped bacteria begin to multiply as immune cells.
When you sit for prolonged periods, simple downward friction forces the hair on your lower back to bend and eventually snap under the weight. These loose, broken hairs collect and travel down the intergluteal cleft, the vertical groove between the buttocks. This mechanical accumulation was so prevalent among World War II military personnel bouncing on hard vehicle seats, it earned the clinical nickname Jeep disease. Trapped in that narrow, friction-heavy furrow, the sharp end of the broken hair physically pierces the softened, moistened skin, or slips directly into the open mouth of a sweat gland. Looking at this cross-section of the skin, you can see the core mechanical failure at play. The intermittent pressure of sitting and walking acts as a biological vacuum. Every movement creates that sucks more loose hair, debris, and skin cells downward into this new pit. Deep in the subcutaneous tissue, that single pit multiplies into a complex network of branching side channels. The immune system reacts, deploying specialized foreign body giant cells to try and digest the trapped hair, but they fail against the dense keratin structure. This creates an expanding underground trap filled with decaying matter. It lacks the internal itself, guaranteeing the defect will grow until it is mechanically dismantled. Patients typically first notice a small swelling near their tailbone. As the trapped debris accumulates and becomes infected, that small pimple quickly progresses into a highly painful 2 by 2 centimeter abscess. The localized infection causes the surrounding tissue to swell and turn red. Eventually, the pressure forces a blood-stained, foul-smelling discharge to surface, often carving secondary drainage openings directly through the skin. While this happens most frequently on the lower back, this mechanical trap forms anywhere friction forces loose hair into skin crevices.
men's barbers routinely develop identical sinus tracts in the soft interdigital webs between their fingers from customer hair. Because the disease builds a self-sustaining, branching network of decaying matter, a success must be invisible ramifications of the sinus to ensure no infected tissue remained. In this top-down diagram, we see the diagnostic mapping phase. Flooding the main pit with methylene blue dye, surgeons stained the entire underground, forcing previously unseen side channels to reveal themselves. With the tracks mapped, the traditional open excision begins. Surgeons carve a wall completely around the dyed tissue, cutting vertically down to the fascia covering the sacrum bone, removing the entire infected mass in one piece. Attempting to pull the edges of this massive void together and suture it shut creates intense physical tension on the skin, which consistently forces the wound to tear open and the disease to recur. To prevent that tension, surgeons leave the wound wide open, gauze, forcing the body to heal from the inside out through 4 weeks of intense, daily dressing changes. Traditional wide excision achieves total disease eradication, but it requires destroying massive amounts of healthy collateral tissue and subjects the patient to a grueling physical recovery. When an abscess risk, plastic surgeons solve this using geometry. The diagram illustrates a tissue plane where surgeons deliberately carve the infected zone into a precise diamond-shaped tissue defect, leaving a specific pattern of adjacent healthy skin intact. They perform a rhomboid flap repair. By cutting and rotating that exact mathematically outlined flap of skin into the void, the design closes the wound and distributes the physical tension forces equally across all 4 planes. Surgeons treat severe, recurrent pilonidal disease as a structural engineering problem. They bypass the natural tension limits of human skin, load. Today, patients have a minimally invasive alternative that avoids large-scale tissue removal entirely, operating through a single 1-centimeter incision. Working through this micro-incision, surgeons manually extract all the trapped hair and debris, completely clearing the internal cavity while leaving the tunnel walls intact. They insert a precise 1470 nanometer diode laser into the empty tracks. As the glowing fiber optic tip slowly retracts, it physically burns and ablates the infected superior and inferior tracts from the inside out. Surgical methodology has moved from brute force anatomical excavation to precise thermal targeting. The laser destroys the infected lining while perfectly preserving the surrounding healthy tissue. The recovery rates are drastic. Traditional open surgery demands a month of agonizing bed rest. Laser ablation allows for same-day discharge and requires only a basic 5-minute betadine dressing. Regardless of how precisely the surgeon operates, one vulnerability remains. If a new, loose hair grows and falls into the fresh healing wound, the entire disease cycle instantly restarts. To protect the surgical site, patients must adhere to strict post-operative hygiene, including meticulous and continuous hair removal around the lower back until the area is completely sealed. Medical engineering has mapped the defect, calculated the tension loads, and developed lasers to vaporize the infection. Yet the ultimate cure relies heavily on the patient enforcing behavioral changes so the mechanical forces of friction never trap them again.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
In the first 24 hours of life, a newborn must pass meconium. During normal fetal development, pushes upward. Ideally, these structures meet to create a single continuous channel. When this fusion fails, the child is born with an imperforate anus, leaving the digestive pathway physically obstructed. These clinical illustrations show the result. While the left panel displays normal male pelvic anatomy, the malformation on the right shows the rectum terminating blind with no anal opening. The critical landmark here is the pelvic floor, a muscular sling supporting the internal organs. By mapping exactly where the bowel stops relative to this muscular divide, surgeons can classify the case as either a low or high anomaly. In a low anomaly, the bowel successfully passes through the pelvic floor, but stops just millimeters short of the skin. These
membrane blocking the exit, a bridge of skin covering the opening, a microscopic narrowing of the canal, or an opening that is simply shifted too far forward. Because the bowel has already crossed the pelvic floor boundary, the crucial sphincter muscles use developmental errors. They typically require only physical corrections, such as small incision. The infant is then held upside down with a metal marker taped to the skin where the anus should be. The buoyant gas rises to the dead end of the rectum, creating a distinct dark shadow. Surgeons then measure the distance between that gas pocket and the bright metallic marker on the skin. This measurement is definitive. If the gap between the gas shadow and the metal indicator is more than 2.5 centimeters, the defect is classified as a high anomaly. In high anomalies, the anal canal never forms, and the rectum terminates blindly above the level of the pelvic floor. Without a natural exit, the digestive system often pathways called fistulas. High anomalies in males often involve fistulas dumping waste directly into the bladder or urethra. The rarest female anomaly is the cloaca, shown bottom right, where the hindgut, bladder, and genital tract empty into a single shared cavity. A high anomaly is a complex anatomical failure. Correcting it requires surgeons to disconnect these rogue pathways and entirely reroute the pelvic structures. The definitive surgical solution for these cases is the abdominoperineal pull-through operation. First, surgeons mobilize the trapped rectum down the midline of the pelvic floor muscles. Finally, the rectum is pulled through this tunnel and sutured to the skin, creating a permanent, functional opening. Using the pelvic floor as a definitive anatomical coordinate allows surgeons to bridge the physical gap created during development. This surgical reconstruction resolves the life-threatening blockage, providing the newborn with a functional. When we hear the word benign in a medical context, it's resolved itself into something entirely harmless. But inside the dynamic regenerating environment of the lower gastrointestinal tract, that definition falls apart. In the rectum, a benign diagnosis simply means a growth is not yet cancer. It is a highly unstable status. The clinical image captures exactly what these anomalies look like and deceptively innocuous. This presents a complex diagnostic challenge. When a gastroenterologist encounters a mass like this, they must determine if the growth is a static structural quirk or a precursor to invasive disease. The only way to accurately assess that danger is to map the tumor's exact location within the anatomical architecture of the rectum. We start at the mucosa, the surface lining of the rectum. This uppermost layer shares the same types of polyps found higher up in the colon. The lowest threat anomaly found here is the juvenile polyp. As the name suggests, highly prevalent in children, and it typically grows on the end of a long stalk, known as a pedicle. This diagram illustrates the straightforward mechanical solution for a juvenile polyp. Because of that long stalk, a tissue by tightening a loop around the pedicle, tying it off, and cutting the tumor away entirely. The medical math gets more complicated with the adenoma. Continue to debate the exact statistical probability of these specific tumors turning malignant. Despite that debate, their mere presence demands navigate a sigmoscope, a lighted viewing tube, into the rectum, capture the fleshy mass with an electrified metallic snare, and cleanly sever it from the mucosal wall. The ultimate surface-level threat is the villus adenoma, and expand until it completely fills the rectal cavity. A tumor this size causes systemic chaos. The villus adenoma secretes profuse amounts of thick mucus loaded with potassium, draining the patient's bodily fluids and triggering severe electrolyte imbalances. There is no debate about its biology. This tumor is a direct precursor to carcinoma. As its physical footprint increases, its tendency to mutate into lethal cancer rises in direct proportion. Transanal endoscopic microsurgery. The process begins and flooding the cavity with carbon dioxide. Inside this inflated workspace, surgeons use elongated instruments to meticulously excise the growth. Defeating these surface-level threats requires a linear escalation of technical intervention, scaling directly with the physical size and malignant potential of the growth, away from the surface lining, and plunge into the submucosa, the deeper, fibrous tissue directly beneath. Here we find the benign lymphoma. Despite originating deep in the tissue, it pushes upward to present as a firm pink to grayish nodule.
It affects men and women of all ages equally and requires only a simple local excision. The endometrioma behaves entirely differently. This is a highly specific systemic interloper that almost exclusively affects women between 20 and 40 years of age. This chart demonstrates the tumor's peculiar symptom profile. It creates constricting, bleeding lesions deep at the rectus sigmoid junction, where the colon meets the rectum, with flare-ups linked entirely to her menstrual cycle. Because the tumor is the surgical scalpel is often abandoned. Doctors instead prescribe ovulation-inhibiting pills, deploying hormones to force the it compromises the blood vessels themselves. It causes severe bleeding, forcing extensive excisions, while carefully conserving the patient's sphincter. Tumors are complex biological interlopers. They force doctors to discard standard mechanical removals and deploy radically different origin-based treatment strategies. A diagnosis of a benign neoplasm in the lower GI tract is never a reason for inaction. It is a fleeting window of opportunity. Securing that window requires a vast spectrum of medical responses. It ranges from mechanically tying off a childhood polyp with a simple wire to deploying systemic hormonal suppression against a deep tissue endometrioma. Identifying the exact anatomical layer of the threat, whether it sits visibly on the surface mucosa or hides deep in the submucosa, determines which specialized procedure is required to neutralize it.
Tumors are non-cancerous growths from the rectum until painless bleeding shows up on the toilet paper. They often start as polyps, tubular villus or tubulovillus adenomas, hyperplastic polyps, inflammatory hamartomatous polyps, and lipomas. Each has a different cancer risk. Some people get mucus discharge, constipation, altered bowel habits, or a feeling of incomplete emptying, and occasionally a polyp that prolapses. To see what's really there, the gold standard is colonoscopy. A scope passes through the rectum, and the mucosa appears moist with natural vascular markings. Your colorectal surgeon guides the camera, takes a biopsy, and may use CT or MRI for larger lesions. Most tumors can be removed during the procedure with snare polypectomy or endoscopic. Bigger ones may require transanal minimally invasive surgery or conventional surgery. Early detection and complete removal can prevent colorectal cancer. Screen early, remove early, prevent cancer.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
When treatments fail, internal hemorrhoidal veins swell and inflame. This 3D cross-section shows 3rd and 4th degree hemorrhoids prolapsing past the anal margin. Under anesthesia, the surgical map has 4 layers: swollen vein, overlying mucosa, internal sphincter muscle, and the dentate line, marking highly sensitive tissue. The surgeon must remove the vascular tissue while preserving the underlying sphincter muscle. Any significant damage to the muscle or accidental shrinking of the passage can lead to permanent complications. Because the anal canal is a narrow pressure space, the choice of technique depends on how precisely the surgeon can excise tissue without compromising the structural integrity of the canal. In a closed hemorrhoidectomy, the surgeon uses a scalpel to remove the swollen vein and its overlying mucosa as a single unit. The wound is then closed from the top of the pedicle down to the anal margin with a continuous. Pulling these mucosal edges together often results in marked stenosis. As the sutures tighten, the anal canal's diameter physically narrows. The submucous technique addresses this narrowing by preserving the lining. A vertical incision allows the surgeon to lift mucosal flaps and dissect the hemorrhoid away from the sphincter muscle, leaving the surface tissue intact. While this post-operative shows a recurrence rate of 14% within the first 6 months. The recurrence risks and technical complexity of manual dissection led to mechanized surgical solutions. The staple technique begins with the insertion of a dilator to reduce the prolapse. A purse string suture is then woven into the tissue exactly 5 centimeters above the dentate line. This placement puts the suture well above the actual prolapse tissue, targeting the upper anal canal. Tightening the purse string draws the redundant mucosa upward into the stapler casing, back into its original anatomical position. The stapler degree cut, removing a ring of tissue and sealing the wound with staples.
The device is held closed for 30 seconds to act as a tamponade, before being withdrawn to reveal a clean staple line. By performing the excision high above the sensitive dentate line, this method reduces postoperative pain and avoids the structural narrowing traditional suturing. Recovery is managed through a specific pharmacological window. As seen on this chart, local anesthetics like liposomal bupivacaine keep the pain line flat for 72 hours, but patients experience a sharp increase in sensation on the third day as the medication wears off. Maintaining the surgical site depends on the mechanics of first bowel movement. Bulk-forming fibers must be paired with high water intake. Without sufficient hydration, the fiber creates a hardened mass that can tear the surgical repair. The mandatory protocol includes 3 daily sitz baths, stool softeners, and a million glasses of water. If a bowel movement has not occurred by day 4, a fleet enema is used to prevent the stool from hardening. These 3 techniques represent different anatomical strategies. The closed method relies on total excision and suturing. The submucosis method uses flaps to preserve width, and the stapled method uses mechanical repositioning above the dentate line. Resolving advanced hemorrhoids requires a precise match between the spatial mechanics of the surgery and the patient's commitment to hydration-focused recovery.
In a healthy anorectal junction, a tissue network acts as a physical seal. These naturally occurring vascular cushions cause problems when their blood vessels become heavily engorged. They swell, stretch, and prolapse or bleed during bowel movements, creating deep discomfort. Historically, many patients have suffered through this severe discomfort in silence. There is a reputation for intense post-operative pain and lengthy hospital stays. Has moved beyond a one-size-fits-all surgical mandate. Today, doctors rely on a specific 3-tiered escalation pathway. This tiered framework allows doctors to match the intensity of the treatment to the severity of the disease, ensuring the intervention is no more invasive than it needs to be to achieve permanent relief. The first tier of intervention is designed for early-stage internal hemorrhoids that cause merely at the base of the swollen vascular cushion blood supply. The pinpoint heat cauterizes the tissue on contact. Deprived of blood, the problematic hemorrhoid simply shrinks and disappears into the canal wall. Because of how shallow the intervention is, this is a fast outpatient procedure. It takes only a few minutes, involves little to no pain, and patients walk out of the office and return to their normal activities immediately. For early-stage issues, this heat provides a rapid resolution. The problem is solved without requiring any structural damage to the surrounding anatomy. If the condition progresses to a moderate stage, the treatment moves to the middle tier, cryosurgery. Here, the clinical mechanism swaps targeted freezing. The doctor applies a specialized probe, cooled by liquid nitrogen to negative 160 degrees Celsius, directly to the pedicle, or stalk, of the hemorrhoid. They hold it there for exactly 3 minutes. You can actually watch an ice ball form over the tissue. This freezing process induces cellular necrosis, tissue death, meaning the diseased mass will eventually slough off on its own. But there is a significant clinical trade-off. While freezing the tissue makes the procedure painless, the resulting necrosis triggers a profuse protein-rich discharge that can last for several weeks. The patient avoids the pain of a surgical cut, but they pay for that comfort with a highly inconvenient recovery period, requiring the use of surgical pads for up to a month. Finally, for severe third-degree prolapsed hemorrhoid with excision method. Operating under anesthesia, the surgeon begins by making a precise V-shaped incision adjacent to the primary pile. The surgeon carefully dissects upward, manually separating the diseased pile from the healthy subcutaneous muscle beneath it, isolating the mass into a newly formed pedicle. Next comes the removal. The surgeon transfixes this stalk with a stout ligature, using thick silk or catgut to tie it off, before excising the diseased mass. Final surgical site, you'll notice a critical piece of finesse. Between the excision points, the surgeon intentionally leaves continuous bridges of intact anal mucosa. These unbroken bridges are a biomechanical necessity. If the surgeon tissue, the wound healing process would cause postoperative stenosis, a permanent narrowing of the anal canal. While this method requires hospital time and a painful recovery, it is the only way to achieve lasting relief for a severely prolapsed anatomy. Burn, freeze, or cut.
These are the three mechanical pillars of the modern medical spectrum. Are now categorized this precisely. The era of delaying treatment out of fear of the scalpel is over. A patient with minor bleeding will not be subjected to traditional surgery, and a patient with a severe prolapse will not waste time on surface therapies that cannot fix the underlying issue. Medical science now calibrates the
And subscribe to the channel to get
Hemorrhoidectomy. For the best recovery, follow these instructions closely. Expect some pain for 1 to 2 weeks, especially with bowel movements. Take prescribed pain medicine as directed and consider warm sitz baths for 10 to 15 minutes, 3 to 4 times a day, and after bowel movements. Avoid constipation by drinking plenty of water, eating high-fiber foods like fruits, vegetables, and whole grains, and using doctor-approved. Avoid straining. Some light bleeding is normal for a few days, so gently wash and pat dry. Walk several times a day, but avoid heavy lifting, cycling, or prolonged medications. Go to your follow-up appointment so your surgeon can check healing.
hemorrhoidal veins that drain this area completely lack the internal valves that normally keep blood flowing upward. Furthermore, they pass right through the thick rectal musculature, which can pinch them shut during digestion. Without valves to support the vertical column of blood, the weight of intra-abdominal pressure pushes downward. Blood pools at the lowest point of these unsupported veins, stretching the loose connective tissue housing them. What we commonly call hemorrhoids are a direct consequence of this. They are the result of human anatomy yielding to chronic, compounding gravitational pressure. Because this system is constantly under tension, it takes very little to trigger an internal structural collapse. A low roughage diet often leads to straining, which adds a tense spike of downward. Once they yield, the venous plexuses prolapse below the anorectal ring, forming internal hemorrhoids. Due to blood vessel branching, these structural failures predictably occur at the 3, 7, and 11 o'clock positions. Occurring high up in the anal canal, these bulges remain covered by the bright red and purple mucous membrane of the internal, largely hidden from the outside. Straining isn't the only trigger. Any secondary biological event that adds intense intra-abdominal pressure, like a pregnancy or large uterine tumors compressing the superior rectal veins, can force this exact same internal collapse. Ultimately, these internal hemorrhoids are the direct, measurable result of suspended biological pillars buckling completely on a biological border called the dentate line. Below this line, the terrain-sensitive internal mucous membrane ends, transitioning into standard skin at the anal orifice. This external zone takes the brunt of acute, sudden spikes in back pressure. Activities like violent coughing or holding your breath while lifting a heavy weight rapidly force pressure down into the tiny anal venules. When that pressure hits the exterior network, it causes a venous blowout in the perianal right beneath the skin. The trapped blood clots, creating a condition defined as a perianal hematoma or a thrombosed external hemorrhoid. Because this occurs under highly innervated skin, the physical presentation is immediate. It forms a sudden, painful, tense swelling lateral to the anal margin. The dentate line creates an agonizing, exposed symptom profile. Wearing fix is mechanical. Under local anesthesia, a surgeon makes a small incision to extract the clotted halves of the hemorrhoid, instantly relieving the trapped pressure and allowing the tissue to heal. Diagnostic precision is vital because not every external protrusion indicates a venous failure. A sentinel pile, for example, often mimics the look of a hemorrhoid, but is actually the result of an anal fissure, a tear in the lining rather than a structural collapse of the veins. Zooming out, this entire biological system represents an ongoing clash between our evolutionary history and our modern habits. We took an internal plumbing system designed for walking on all fours and stood it upright. The simplest mechanical solution to prevent collapse is to lower the daily strain on the system. Adding bulk-forming compounds and high roughage foods to a diet reduces the downward force required to expel waste, protecting the suspensory ligaments. For most patients, the earliest sign of hemorrhoidal disease happens in the bathroom. Painless, bright red attic, but causes absolutely no physical pain. Patients ignore the symptom for months or even years. In this cross-section of a healthy anal canal,
The internal hemorrhoidal plexus rests above the dentate line, secured by the mucosal suspensory ligaments, structural bands. Excessive straining creates high venous pressure, forcing these veins to engorge, stretch, painlessly rupture. Allowing this early bleeding to continue unchecked permits a progressive mechanical breakdown of the anal canal suspensory structures. Before initiating any hemorrhoid treatment, a clinician must evaluate the patient using a sigmoidoscopy and an occult blood test of the stool. These serious underlying diseases that also cause rectal bleeding, such as Crohn's disease, ulcerative colitis, or colon cancer. Once serious diseases are excluded, this early stage is diagnosed as a first-degree hemorrhoid. The internal vessels are engorged and actively bleeding, but they do not physically prolapse, and mild laxatives regulate the bowel. Topical ointments reduce local swelling and tissue edema. Physicians employ sclerotherapy for continued bleeding. A needle delivers a phenol solution into these, pulls the mucous membrane upward, locking it tightly against the inner muscle. Intervening at the first degree stops the bleeding by chemically reinforcing the structural integrity of the anal canal before the supporting ligaments are stretched permanently. As the untreated veins grow steadily larger and heavier, the mucosal suspensory ligament eventually gives way under the load, causing structural collapse. This milestone marks a second stage to reduce or pull back inside spontaneously afterward. By the third degree, the structural failure is so severe that the prolapse no longer returns naturally. The patient must manually push the tissue back into the anal canal, where it then stays reduced. A new primary symptom emerges at these stages: profuse mucus discharge. The mucous membrane is now constantly engorged and exposed, leaking fluid continuously. This excess mucus softens and excoriates the surrounding perianal skin, leading to severe pruritus ani, to a gross mechanical failure of mucosal support. At this stage, early treatments like sclerotherapy are strictly contraindicated. The final stage is the fourth degree. The hemorrhoids are permanently prolapsed, completely exposed. While pain is notably absent in earlier stages, it now becomes the dominant symptom as acute complications take hold of the exposed tissue. One major complication is external anal thrombosis, an acute, extremely painful swelling right at the anal verge, driven by high venous pressure. A dangerous mechanism is sphincter muscle grips and chokes the prolapsed hemorrhoid, impeding venous return. Blood flows in but cannot escape, causing massive congestion. If arterial supply is also constricted, the starved tissue turns gangrenous, leading to severe infection. The fourth degree represents total mechanical failure. A previously painless bleed has evolved into a cascading surgical emergency that requires a full hemorrhoidectomy. Once the structural anatomy of a hemorrhoid is established and are stretched out, the physical damage is almost never reversible on its own. However, early medical intervention is highly effective. Injection therapy applied to first and small second-degree hemorrhoids achieves a cure rate of nearly 95%. Understanding the staging of this disease allows patients to seek conservative management while the condition is still highly curable and completely painless. Proactive medical management halts the structural failure of the anal canal, successfully bypassing permanence and the need for invasive surgery entirely.
Rubber band ligation. Surgeons for years had been searching for a simple method of ligating hemorrhoids without the need for a general anesthetic or admission to hospital. Rubber banding is the ideal method of treating large first-degree and second-degree internal hemorrhoid in absence of associated tags or external hemorrhoidal component. Each hemorrhoid is visualized through a proctoscope. The upper part of the mucocutaneous line is grasped by an instrument and a small elastic band slipped over it. The upper part of the mucocutaneous line is grasped by an instrument and an elastic band slipped over it. A recent modification uses a modified proctoscope with bands stretched over inner drum and pushed off by advancing the outer drum of the proctoscope over it. The tissue distal to the elastic band undergoes necrosis and muscle underneath. Rubber band ligation is done with little or no or larger piles than some options. The key is placement. Slide the band so it traps the base of the hemorrhoid at least 1 centimeter above the dentate line. If the dentate line is inside the band, pain can be intense. For each hemorrhoid, place 2 bands at once. This lowers the risk of secondary bleeding. After the bands are in, the ligated tissue necroses within 24 to 48 hours and sloughs off in about 7 days. The main downsides? Pain for the first day or two, sometimes very severe, and the possibility of secondary hemorrhage. You can band 1 or 2 hemorrhoids at a time. Avoid banding 3 large ones together, since ulceration can spread and lead to stenosis. If all goes well, you're reviewed after 1 month, and any remaining hemorrhoids are banded or injected as needed, then decide.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
For adults between the ages of 30 and 50, it is one of the most agonizing physical conditions they can experience. Yet the physical injury responsible is often microscopic. We are looking at a fissure in ano. The condition almost always begins with a single mechanical incident, the passage of a hard, constipated stool that physically stretches and shears the delicate tissue lining the anal canal. This initial tear starts precisely at the proximal dentate line. Because this specific region of skin is packed with an incredibly high density of somatic pain receptors, a cut measuring only millimeters in length, debilitating outside agony. That immense pain is a catalyst. It triggers a cascading structural failure within the body's local anatomy, turning a simple cut into a chronic trap. To understand why these tears happen, we have to recognize that the anal canal isn't a uniform, perfectly protected wall of the canal. This animated diagram outlines 3 biomechanical reasons for that posterior vulnerability. First, the canal has a sharp posterior angulation. Second, the opening itself is elliptical, stretching the tissue. Finally, the fibers of the external sphincter muscle physically diverge at the back, leaving the posterior tissue dangerously unsupported against. This bar chart shows exactly how that structural flaw plays out statistically. In men, in both demographics, acute fissures are highly predictable mechanical failures exploiting the body's natural architectural weak points. When the delicate anal skin tears, the body reacts instantly with a flawed defense mechanism. The internal sphincter muscle violently and involuntarily spasms in an attempt to protect the wound. This spasm clamps apart and torn open all over again. Looking at this cross-section of the constricting internal sphincter, you can see the invisible consequence of the spasm. The tightly clamped muscle physically crushes the local blood vessels, severely restricting the red blood flow that the tissue desperately needs to repair itself. This creates a grueling daily reality for the patient, on a sharp, biting, burning pain that often lingers for an hour or more, accompanied by intense itching, known as Pruritus ani, and bright, visible wound guarantees future trauma. When an acute tear is constantly re-torn and starved of blood, it eventually crosses a biological threshold. It physically deepens and transforms into a chronic fissure. This clinical schematic details the new physical geography of the chronic wound. The microscopic cut has eroded into a deep, canoe-shaped crater with thick, swollen margins. The skin is entirely gone, exposing the bare fibers of lips, known as a hypertrophied papilla. At the lower boundary on the external tag of skin emerges. Clinicians term this a sentinel pile because it forms guard at the base of the ulcer. At this stage, the fissure is a fully established, fortified ulcer structure that the body can no longer heal on its own. In the clinic, the physical exam begins with the visible evidence of the body's defensive response, a tightly closed, puckered anus, often guarding a prominent sentinel skin tag. Diagnosing the full extent of the crater presents a severe physical hurdle. Combined with the involuntary muscle spasms, makes a standard digital rectal exam virtually impossible to perform. To physically inspect the chronic wound, doctors must deploy specific medical workarounds. They often apply a 5% xylocaine surface anesthetic to numb the region, or in severe cases, escalate to full general anesthesia just to force the sphincter muscle to relax. Clinicians must bypass the body's intense defensive barriers to see what truly lies beneath. Visual is mandatory because a painful anal ulcer is not automatically a benign mechanical fissure. It can easily be a local manifestation of a severe systemic disease. Doctors must differentiate a mechanical fissure from tuberculosis by analyzing the structural edges of the wound. A TB ulcer presents with deeply undermined, hollowed-out edges, rather than the thick, swollen margins typical of a chronic fissure. When fissures appear in multiple perianal locations, the clinical focus shifts away from simple trauma. These multiple sites signal systemic inflammation of all is early-stage carcinoma of the anus. If a physician has any doubt about the nature of the lesion, they must surgically excise the tissue and submit it for a histological biopsy to definitively rule out cancer. Finally, doctors must rule out phantom mimics like proctalgia fugax. This condition causes severe, cramp-like night pain driven solely by spasms in the pubococcygeus muscle, producing intense agony without any physical ulcer actually being present. Fissure in ano is driven by a brutal mechanical cytic precision, ensuring the patient's warning sign of a much greater hidden threat.
From the surgical vantage point of any position, the distinction between an acute and a chronic anal fissure becomes morphological. An acute tear is superficial, but a chronic fissure presents a midline ulcer embedded directly into the mucosal wall. The internal anal sphincter muscle enters a state of release on its own. Flowchart demonstrates exactly why the tissue fails to regenerate. The extreme spasm of the sphincter cuts off localized blood flow, inducing ischemia. Of oxygen prevents the superficial ulcer from healing, which in turn increases local pain, triggering an even tighter muscular spasm. Regardless of the specific intervention chosen, the primary clinical goal remains singular. The internal sphincter spasm must be internal sphincter, most commonly glycerol trinitrate ointment. Nitric oxide functions as a neurotransmitter that dictates smooth muscle relaxation. When introduced to the anal canal, it chemically induces the internal sphincter to relax, breaking the hypertonic spasm and restoring necessary blood flow to the tissue. The clinical limitation of glycerol trinitrate is its systemic absorption, which frequently results in severe headaches. To bypass this side effect, modern protocols often substitute calcium channel blockers, like diltiazem, to achieve the required muscular relaxation. Pharmacology reaches its limit when the physical morphology of the wound shifts.
Over time, a simple acute ulcer transitions into a chronic lesion, developing deep, rigid fibrotic edges and external skin tags known as sentinel piles. Once this thick structural fibrosis is entrenched, chemical relaxation is no longer sufficient to allow healing. At this threshold, surgical intervention becomes mandatory. The most historically surgical approach to disrupting sphincter hypertonia is mechanical force, standardized as Lord's procedure, or anal dilation, and middle fingers of both hands simultaneously into the anus, physically pulling the sphincters apart to achieve maximal dilatation. The mechanical objective is blunt: forcibly stretch any constrictions and manually iron out the dense fibrosis surrounding the fissure to restore failure condition. Fissure is accompanied by excessive rigid fibrosis, or a sentinel skin tag. Lord's procedure is almost guaranteed to fail. While this blunt stretching allows the patient to be discharged the exact same day, there is a severe clinical trade-off. The extensive microtrauma inflicted on the sphincter guarantees the period of fecal incontinence lasting up to 10 days. Permanent trauma of manual dilatation, surgeons developed the posterior sphincterotomy and fissurectomy, a direct, targeted division of the muscle. The op begins by introducing a well-greased sim speculum. This retracts the surrounding tissue and provides the surgeon with a direct, unobstructed view of the transverse fibers running across the fissure floor. Looking at this cross-section of the anal anatomy, we see the absolute most critical technical nuance of the procedure. The scalpel must divide only the superficial transverse fibers of the internal sphincter. The deep penetrating directly through the midline of the fissure, the surgeon can concurrently excise the deep fibrotic edges of the ulcer and remove any sentinel piles, creating a perfectly smooth wound bed. This precision requires a rigorous postoperative protocol. Patients are restricted to a liquid diet for 2 days, followed by mandatory daily hip baths and the regular insertion of anal dilators to prevent premature strictures until the wound is absolutely closed. The posterior approach effectively smooths the fissure floor and facilitates direct tissue excision. The cost, however, is a severely prolonged convalescent period of 7 to 10 days, along with a persistent risk of mucus discharge. To minimize that 10-day recovery burden, surgical technique underwent a spatial reorientation, resulting in the lateral anal sphincterotomy. This technical diagram details the anatomical shift.
Rather than cutting through the compromised tissue of the fissure itself, the internal sphincter is divided entirely away from the pathology, accessed from either the right or left lateral position. Relocating the incision to healthy lateral tissue yields an immediate clinical advantage. Hospital stays drop to roughly 4 days, and overall convalescence accelerated. Because the lateral incision is distant from the ulcer, simultaneous excision of fibrotic edges or direct tissue biopsy cannot be performed during the operation. This lateral blind division introduces severe new variables. Surgeons report localized hematoma and abscess formations, alongside a startling 10 to 12% rate of permanent impaired stool control. The lateral approach prioritizes rapid recovery over direct tissue management. This makes it appropriate only for early cases, where complex, localized fibrotic excision is not yet required. To entirely eliminate the risk of incontinence caused by early attempts at this involved lifting adjacent anal skin over the canal defect, a procedure known as VY anoplasty. These simple grafts reliably failed to integrate. The successful modern iteration of this concept is the anal advancement flap. In this spatial schematic, we see the preparation phase. The surgeon carefully excises the fibrotic edges of the fissure and then mobilizes a complete full-thickness flap of healthy, indicating full-thickness skin instead of mechanically dividing hypertonic muscle. The surgeon completely circumvents any structural damage to the internal sphincter, reducing the risk of iatrogenic incontinence to near zero. Balancing the probability of ulcer healing against the severity of physician-induced complications. This comparative matrix plots the operational realities. The rapid 4-day recovery of a lateral sphincterotomy contrasts sharply with the 10-day burden of the posterior approach. However, that speed risks a 12% permanent incontinence rate, a liability neutralized by the sphincter-sparing advancement flap. What remains clear is that blunt, generalized applications of force, like Lord's procedure, are obsolete when confronted with complex morphology like entrenched fibrosis or sentinel piles. Surgical patient-specific ulcer.
And subscribe to the channel to get notified about future informative videos.
The human pelvis is defined by a central paradox. Its largest negative spaces, the ischio-anal fossae, actually dictate the trajectory of its most severe infections. These paired fascia-lined spaces sit beside the anal canal, wedged firmly between the sloping pelvic diaphragm and the rigid lateral wall of the ischium. The space maintains a distinct wedge geometry. In a standard adult, it measures 5 centimeters vertically, 5 centimeters antero-posteriorly, and 2.5. Technically, this space functions as a highly compressible dynamic fat pad. This specific composition allows for the extreme lateral expansion of the rectum and anal canal during defecation, providing a yielding zone for the canal to widen into. Without this compressible negative space, normal anorectal function would be mechanically sits the funnel-like levator ani and external anal sphincter. These walls converge superiorly at the apex, fusing the obturator and anal fascia. Boundary is created by posteriorly, the space is anchored by the sacrotuberous ligament and the lower edge of gluteus maximus. These rigid osteomuscular borders form a pressurized container. Any volumetric increase within the space, such as an abscess, has extremely limited pathways for expansion. Though it appears as a single cavern, the fossa is heavily partitioned by a network of microscopic, robust fascial layers. 3 primary linings define these internal zones: the obturator fascia laterally, the anal fascia medially, horizontal perianal fascia at the base. These layers specifically between the lunate fascia and the perianal fascia. At the very bottom lies the perianal space. This zone is unique because it is further subdivided into tiny compartments by tight fibroelastic septa. Lining the deepest part of the fossa is the arched lunate fascia. On its lateral side, the lunate fascia to form the crucial medial wall of the pudendal canal. These fascial subdivisions act as selective anatomical barriers, directing the flow of disease and dictating exactly which compartment a surgeon must drain. The pudendal canal, or Alcock's canal, runs along the lateral wall. It houses the internal pudendal vessels and the pudendal nerve. From this canal, the inferior rectal vessels and nerves emerge.
They must traverse straight through the fat pad to supply the anal canal. The anterior recess is a forward fossa actively communicate with each other through a distinct gap behind the anal canal. While the fossa provides a conduit for vital nerves, its complex recesses and posterior midline communication create a highway for bilateral infection. This axial CT scan provides a radiographic baseline. Healthy ischiorectal fat appears as dark regions, labeled here as 80. If a patient suffers from severe debilitating disease, the rapid loss of this specific fat pad removes crucial mechanical support from the rectum. This loss of lateral support is a primary cause of rectal prolapse, where the rectum protrudes through the anal orifice. Muscular defects also compromise the space. Normally, the levator ani originates from the arcus tendineus, a thickened area of the obturator fascia, seen here as the white arcuate line. In some cases, for the herniation of peritoneum or fat directly into the ischioanal fossa. A fistula in ano is an abnormal, infected tunnel connecting an internal opening in the anal canal to a secondary opening on the perianal skin. These typically result from an internal abscess that bursts and tracks outward through the tissues to the surface. The Parkes classification maps these tracks through the sphincter muscles and fat planes. Intersphincteric and transsphincteric pathways breach the barrier directly. Suprasphincteric and extrasphincteric pathways utilize the full vertical extent of the fossa, bypassing sphincters entirely by looping through the fat. When infection utilizes the posterior communication gap, it creates a horseshoe abscess. An infection starting on one side of the pelvis uses this specific posterior recess to rapidly contaminate the opposite fossa. Pathological imaging reveals this process in detail. These white arrows indicate gas pockets and abnormal fluid tracts, signals of infection ripping through the tissue planes. Radiographic chaos. The ischiorectal fossa is a wedge-shaped, fat-filled compartment located deep within the pelvic floor. This fatty tissue acts as a structural conduit for internal pudendal vessels and the nerves that serve the perineum. Because the space consists primarily of loose adipose tissue, it offers little resistance to expanding masses. This makes the fossa a frequent site for a wide range of congenital, inflammatory, and neoplastic swelling or pain in this region. The clinical challenge is identifying the specific nature of the mass from a list of dozens of possibilities. Clinicians navigate this variety by categorizing anomalies based on their etiology. Origins fall into three distinct categories: during development, the secondary effects of trauma and infection, and the growth of primary or establishing this taxonomy allows for the differentiation between structural errors and aggressive pathological invasions. Congenital lesion category. These anomalies are present from birth and typically result from the incomplete regression of embryonic structures during fetal growth. This mass, often abnormalities. Similarly, incomplete regression of the embryonic tail gut forms a retrorectal cystic hamartoma, extending into the fossa from the presacral space. Dermoid and epidermoid cysts are also found here, while epidermoid cysts can be caused by the presence of skin appendages, including hair follicles, sweat glands, and occasionally tooth buds. More complex developmental issues include Klippel-Trenaunay syndrome. This mesodermal abnormality manifests as massive, abnormal superficial venous channels that can be visualized through ascending venography. Demonstrate how the fossa can harbor the structural remnants of early human development. The second category includes inflammatory and traumatic conditions. Most infections here do not originate within the fossa itself, but spread from adjacent structures like the anorectum. Radiologists use the St. James's University Hospital classification to map grade 4 transsphincteric punches through the sphincter wall, forming an abscess expanding into the adjacent ischiorectal fossa. A grade 5 fistula travels further upward, crossing over the levator ani muscle before piercing downward through the fossa. Beyond fistulas, the fossa is also vulnerable to trauma. Extraperitoneal tomas can result from childbirth or blunt force, while severe infections can the fossa's role as a reservoir for the collateral damage of surrounding pelvic disease and injury. The final category concerns neoplastic growth. These are divided into primary tumors originating within the fossa and secondary involvement from regional cancers. Primary tumors aggressive angiomyxoma, lipomas, and gastrointestinal stromal tumors. Anal adenocarcinoma is another possibility, though it accounts for less than 10% of all anal canal tumors. Because these masses often produce Bartholin gland cysts. Secondary involvement occurs when common regional cancers, like prostatic or rectal carcinomas, extend beyond their primary site and infiltrate the soft tissue of the fossa. This animation demonstrates how primary bone tumors, such as chordomas, can extend directly from the sacrum and ischium into the rectal fossa. While isolated metastasis advanced pelvic physical examination alone is rarely sufficient for a definitive diagnosis. A benign congenital cyst, a traumatic hematoma, and a malignant tumor can all present with nearly identical symptoms of external swelling. Differentiation requires advanced imaging, specifically CT and MRI, which allow radiologists to evaluate the internal attenuation and tissue density of the mass. As shown here, a Gartner duct cyst displays uniform water-like attenuation on a CT. Coronal dynamic contrast-enhanced MRI, effective tool for identifying structural breaches in the levator plate during the evaluation of complex translevator fistulas. The ischiorectal fossa is a site where developmental history, traumatic injury, and cellular health intersect. Identifying these pathologies accurately depends on the high-resolution tissue characterization provided by modern cross-sectional imaging.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified of videos.
Let's dive into this. The core medical issue we're addressing today is partial rectal prolapse. Basically, it's a condition where the tissue lining the rectum drops down into or completely through the anal opening. Now, initially, doctors will try conservative measures to treat this, right? But what happens when those standard, non-surgical treatments just don't work? How exactly do you fix a partial rectal prolapse when those conservative measures fail? Well, that's the exact focus of our explainer today. How the Thiersch operation steps in to physically and biologically fix this very specific type of prolapse.
For today. First, we'll look at when conservative measures fail. Second, the operation setup. Third, we'll go through the step-by-step surgical procedure. Fourth, the mechanical and chemical support. And finally, complications and pediatric care.
Section 1. When conservative measures fail.
So when those initial treatments fall short, the Thiersch operation is deployed. It's a highly successful success rate across the board. The medical text emphasized that it is almost certain to succeed. And more impressively, it's a viable option for patients of literally any age. That's a really crucial detail we'll expand on a bit later.
Moving right along to Section 2, the Thiersch operation setup. I want you to try and visualize this setup. The entire foundation of the surgery relies on just 2 small incisions. One midline incision is made about ½ an inch away from the opening itself. Tiny gateways are literally all the surgeon needs to begin constructing the support structure.
Now, the crucial tool that goes through those incisions is a 20-gauge wire. The surgeon uses a long, curved needle to thread either a silver wire or a stainless steel wire of this specific thickness. This wire is the essential tactile material used to create the physical support ring that's going to ultimately keep that tissue from prolapsing.
Section 3. The step-by-step surgical procedure.
The whole process is remarkably straightforward. It's almost like threading a drawstring around the waist of a pair of sweatpants. First, that long curved needle is passed from the posterior incision around 1/2 of the anus, emerging at the anterior incision. Second, the 20 through the eye of the needle and pulled completely through so it traverses half the circumference. Third, the needle is taken out, reinserted into that back incision and passed around to meet at the front again, pulling the other end of the wire with it. Fourth, the wire is twisted tight, cut short, and those 2 small incisions are stitched closed.
And this brilliantly illustrates that 4th step. Notice how the surgeon introduces their index finger directly through the anus while the assistant twists the wire. The surgeon isn't relying on a machine or a monitor here, right? They're using their own physical touch. They're actively feeling the tension to gauge exactly how tight that silver or
Visualize that continuous loop being created. The wire completely encircles the tissue, traversing the entire circumference of the anus right under the skin. Once that full loop is made, the assistant twists the 2 ends of the wire together really tightly to secure the knot, which creates a firm, unyielding ring.
The absolute print of this operation comes down to this specific sensory detail. When the finger can be just sufficiently passed through the anus, the twisted wire ends are cut short. It's this fascinating blend of rigid hardware, stainless steel wire, and the delicate, precise biological measurement of the surgeon's own index finger. This ensures the ring is tightened perfectly, not too loose to allow ups, and definitely not too tight to cause obstruction.
Section 4. Mechanical and chemical support. First, we have the immediate physical fix. The suture material is actively passed right through the substance of the internal sphincter. This acts exactly like a tissue from prolapsing outward. It's the obvious mechanical fix. There is a secret secondary weapon at play here.
Now, what's really interesting here is the concept of chemical support. You see, the mere presence of the wire inside the body triggers a localized healing response. The body naturally creates fibrous deposits and scarring around the anal canal right where the wire was placed. So the body's own chemical healing process actually steps in to build a wall of structural reinforcement, vastly stronger than it was before the surgery even happened.
Section 5. Complications and pediatric care.
We noted earlier that patients. However, look at the stark contrast in how it's actually performed. For adults, surgeons use silver or stainless wire and gauge tightness with their index finger. But for children, the surgeon uses strong chromic catgut instead of metal wire, and they must use their little finger as the gauge. The takeaway here is that in children, the stitch literally must be removed. If it's left in as the child grows, it will result in a dangerous narrowing called anal stenosis.
Speaking of removal, even for standard adult cases using the metal wire, the structure isn't always meant to be there forever. If required, the wire after about 3 months. By this time, the body has usually done its work.
So why might it need to be removed? Well, the main complication of this operation, the wound may develop a discharging sinus, which is essentially a tract of infection or inflammation. If this occurs, the wire absolutely must be removed. Complication happens, and you have to pull the wire. Usually, by that time, enough fibrosis further prolapse anyway. And hey, if the prolapse ever does recur in the future, the operation can simply be repeated.
So the crucial point we really want you to take away from this is that the temporary mechanical fix of the wire acts as a scaffold, holds everything in place just long enough to initiate a permanent biological solution. The resulting fibrous deposits leave behind a natural barrier against prolapse that remains long after the wire is gone.
Which leaves us with this final thought. Isn't it absolutely fascinating how a simple carefully threaded and tightened by a surgeon's touch can trigger the body's own chemical healing process to permanently fix such a complex problem? It's really a excision. Let's kick things off with section 1, the prolapse problem. We really have to define the failure before we can even begin to understand the fix. So the absolutely crucial point here is that these surgeries are specifically indicated for symptomatic grade 3 and IV. These are the ones that physically bulge outward when non-surgical tissue bulges out, and this is frequently combined with a partial or the lining of the rectum itself is slipping downward. It's a major structural displacement that demands motion.
Which brings us to section 2. Let's look at system 1, stapled hexy. It's a truly modern, minimally invasive marvel.
The logic is exactly like tailoring. Rather than using traditional methods where you're simply cutting out the hemorrhoidal tissue, this system uses a completely different approach. A specialized circular stapling, it cuts off the blood supply to the hemorrhoids, which forces them to shrink over time. But the real genius is what happens at the exact same time. The device actually pulls and anchors that displaced prolapsed mucosa right back up into its normal, healthy anatomical position. It's literally like taking in the waistline of a pair of pants from the inside.
So how do the mechanics of this actually play out? Well, the procedure cleverly navigates the body's anatomy to minimize pain. After anesthesia and a gentle dilation of the canal, the real magic happens. A circular purse slide inside the rectum, specifically above what's called the dentate line. Now, why does that matter to the patient? Because that area above the dentate line is completely devoid of pain-sensing nerves. Then, the circular stapler draws the excess tissue in, fires a row of internal staples, and lifts everything up. Because everything is done internally above that nerve line, there are absolutely zero external incisions or wounds. It's brilliant, multi-component disease with significant outer skin tags. Surgeons pivot to System 2. As this elegant internal lift, it actually has exclusion criteria. It's just not effective for severe external issues. So System 2 steps in using a traditional scalpel or a modern energy device to physically remove the hemorrhoid columns, alongside a localized mucosal repair.
It's your more direct, traditional strategy when that internal tailoring from System 1 just can't fix the outer external problems.
Next, a very specific scenario. The mechanical precision of what's called Goodsall's ligature is just fascinating. While System 1 handles the entire circular circumference of the canal, if the partial prolapse is isolated to just one specific part of that circumference, surgeons use System 3. They address the base prolapse by transfixing it twice with a ligature. That ligature is tightened to really secure the base, and only then is the redundant mucosa excised. Finally, the cut margins are sutured together. It is a highly targeted, localized approach specifically designed for partial prolapses associated with third-degree.
It's time for a reality check on these 3 engineering feats and what the patient journey actually looks like post-op. The clinical data maps out how the rapid elimination of bleeding and shorter hospital stays have to be weighed against longer-term risks. Looking at the benefits, minimally invasive procedures like System 1 offer incredibly fast recovery times. Patients return to work much sooner, and a lot of them even go home the exact same day. The short-term satisfaction reoccurrence rate, especially risks like anal stenosis, which is a narrowing of the canal caused by internal scarring, and a temporary feeling of urgency or pressure following the surgery. And of course, in very rare cases, there can be severe risks like rectal perforation or pelvic infection. It's a delicate balance.
Post-surgery, all that internal tailoring needs time to set. Patients undergo a 4 to 6 week recovery protocol. While the hospital stay is super brief, the at-home aftercare is absolutely make or break here. To protect those internal sutures and staples, patients have to stick to a strict diet of high-fiber foods, lots of fluids, and stool softeners. The whole goal is to completely avoid any straining or constipation while the tissues fuse into the new anatomical. During those 4 to 6 weeks, light activities are fine, but heavy lifting or intense physical straining is a strict no-go.
It really leaves you wondering exactly how much more precise and seamless these biological engineering solutions can become in the future. We've moved from simple excision to complex internal stapling that actually utilizes the layout of the nervous system to eliminate pain. The logic.
If you found this video
When the supportive structures of the pelvic floor fail, the rectum loses its normal anatomical fixation. This results in a complete, full-thickness rectal prolapse, where the redundant tissue drops downwards, telescoping through the sphincter and protruding outside the body. To correct this, the primary clinical objective is operative management. The surgeon must physically resect the redundant bowel tissue, so the rectum can be secured back into its proper internal position. This module covers 3 distinct surgical pathways to achieve this correction: laparoscopic anterior resection, the perineal approach, Ultimare's procedure, and the Gallagher modification. If medical goals are not met, the patient faces a high risk of permanent anal incontinence. This slide outlines the standard clinical indications and contraindications for laparoscopic anterior resection. High anterior resection is indicated for rectosigmoid tumors, while massive T4 tumors or a particularly narrow pelvis serve as contraindications for this specific approach. These diagrams illustrate the patient positioning and port access. The patient is secured in a Lloyd-Davies lithotomy position using padded Allen stirrups. The map for port placement includes a 10mm camera port just above the umbilicus to provide central visibility for the surgeon. The procedure begins with medial to lateral mobilization. The surgeon retracts the sigmoid colon and makes the initial incision in the peritoneum directly over the sacral promontory, exposing the retroperitoneal space. In this anatomical illustration, the surgeon isolates and divides the inferior mesenteric artery while taking care to spare the left colic artery. The left ureter and gonadal vessels must be continuously identified and protected during this maneuver. This diagram shows the downward progression of the posterior rectal dissection. The surgeon carries the dissection through the avascular plane to the level of the coccyx. Depending on the height, the tissue is mobilized for a partial or a total mesorectal excision. In this 3D view, we highlight a major surgical hazard. The dissection must remain intimately close to the rectum. Staying too far laterally risks severing the hypogastric nerve plexus, glowing here, which provides autonomic control to the bladder and reproductive organs. Once the redundant portion of the sigmoid colon and upper rectum is fully mobilized and the nerves are secured, the excess bowel tension on increases the risk of postoperative leaks and inhibits the tissue's ability to heal.
The abdominal approach offers surgeons excellent visibility and allows for secure fixation of the bowel. However, because it requires it carries a risk of nerve damage if the surgeon violates the established anatomical planes. If the abdominal route poses too much risk, surgeons utilize a perineal perspective. For Altemeyer's procedure, the patient is prone jackknife position, allowing the surgeon to operate directly through. Diagram A shows the opening maneuver. The surgeon makes a full-thickness circumferential incision 2 centimeters proximal to the dentate line. As this incision is deepened anteriorly, the peritoneal cavity is opened. Moving to diagram B, we see the unique exteriorization mechanism of this procedure. The surgeon pulls the redundant pelvic colon downward through the incision until the bowel becomes taut from above. In diagram C, the surgeon ligates the vascular pedicle. Once the blood and the internal pelvic colon, the surgeon then constructs a coloanal anastomose, matching the tissues and suturing them together with a series of interrupted stitches. Alternatively, this sequence illustrates deploying a circular stapler to achieve this. Altemeyer's procedure removes the redundancy without entering the abdomen, however, leaving too short of an anorectal stump during the patient's risk of postoperative anal incontinence. Removing the redundant tissue fixes the immediate protrusion, but long-term success requires addressing the underlying muscular architecture. This view demonstrates a levatoroplasty. The levator ani muscles are pulled together anteriorly and sutured tight. This narrows the pelvic outlet, closing the gap that allowed the prolapse to occur. Next, the surgeon obliterates the deep peritoneal pouches. Suturing these spaces closed removes the anatomical pockets where a future prolapse could begin its descent. The surgeon then sutures the pelvic floor behind the mobilized rectum. This specific fixation pulls the anatomy back into alignment, restoring the natural anorectal angle. A standard perineal pelvic gap vulnerable to abdominal pressure, while the Gallagher modification redirects those forces against a reinforced muscular floor. The Gallagher modification treats the rectal redundancy as a consequence of pelvic floor weakness. By rebuilding the structural integrity of the levator ani, the surgeon provides the physical support necessary. Models demonstrate the restored anatomical baselines achieved by laparoscopic, Altemeyer, and Gallagher surgical approaches. Each procedure successfully meets the surgical knee is restored, and the final anastomosis is flawless anatomical correction. The years of chronic stretching caused by the prolapse can leave the anal sphincters weakened. This results in persistent incontinence for a small percentage of patients. Recovering full control often requires rehabilitating these muscles months following surgery. Targeted pelvic floor exercises and thoracic stimulation work to retrain the sphincter, allowing the patient to regain the continence needed for a normal life. The first step is isolating the correct muscle group. You can locate them by mentally simulating the physical action required to stop the flow of urine midstream. This stopping is only a tool for identification. You should never make a habit of practicing these exercises while you are actually urinating, as frequently interrupting the flow can lead to severe bladder irritation. Begin the long squeeze endurance routine. Actively tighten these muscle layers, pulling them inward and upward for a full 10 seconds. Use the short squeeze protocol. This involves quickly tightening the muscles for just 1 second and letting go immediately, performing a rapid set of 10 repetitions. Using both techniques creates a complete training routine. The slow squeezes develop the baseline endurance needed for all-day support, while the rapid pulses train the fast twitch fibers to react instantly to sudden physical shocks. You can move these exercises into dynamic core movements, such as the floor bridge shown here. The timing of the contraction is key. Engage the pelvic floor before lifting your hips, maintaining internal 3 to 8 second hold. Your breathing directly influences the movement of these muscles. When you inhale, your diaphragm pushes the pelvic floor down. When you exhale, the diaphragm rises, allowing the pelvic floor to naturally lift back up. A common mistake is accidentally engaging the surrounding muscles. Ensure you are not squeezing your glutes, your thighs, or your abdominal wall, as this prevents you from loading the deep internal fiber you are trying to achieve. Prioritize isolation over intensity. A gentle muscles is far more effective for rebuilding your core strength than a forceful, high-effort flex of the larger external muscles. For the best results, perform 3 sets of these exercises daily. Each set should include a combination of the long endurance and rapid response pulses. While your neurological control will improve quickly, the physical tissue takes longer to adapt. It requires several weeks of consistent daily loading for the muscle fibers to visibly thicken and form a denser, more resilient support mesh. The goal is to make this activation reflect. Once the muscles are stronger, you can fire them a fraction of a second before you sneeze, lift a heavy object, or stand up from a chair to prevent any potential leaks. Strengthening this system provides a stable internal floor for your entire torso. By helping manage the internal pressure of your core, these muscles reduce the load placed on your lower back and help stabilize the spine during movement. Mastering these mechanics gives you the tools to manage your own physical response to stress. Consistent practice secures this internal foundation, allowing you to return to an active, confident daily life without the fatigue. Base of the human torso lies the deep pelvis, are the internal and external sphincter muscles, continents, which allows the body to store and release waste precisely when intended. Deep between these two muscular layers, in a narrow gap called the intersphincteric space, sits a row of microscopic anal glands. These glands secrete lubricating fluids that travel down into the anal canal through tiny openings at the dentate line. This precise biological plumbing keeps the canal healthy, but it harbors a microscopic vulnerability: the extremely narrow ducts connecting the glands directly to the internal bowel. When one of these narrow ducts becomes obstructed, the lubricating fluid backs up. Bacteria from the bowel quickly multiply in the trapped fluid, sparking an infection. This causes a painful abscess to form and expand, trapped tight within the confined layers of muscle. With nowhere else to drain, the accumulating pus generates immense physical pressure. The fluid is forced to tunnel outward, carving a path of least resistance through the surrounding healthy tissue. Eventually, this advancing tunnel reaches the surface, rupturing through the perianal skin to drain. The immediate pressure is gone, but physical damage remains. The path the pus carved solidifies into a tough, fibrous track lined with inflamed, unhealthy scar tissue. The result is a permanent structural defect known as a fistula in ano. The body has essentially an abnormal, unhealing tunnel that directly connects the inside of the bowel. A fistula cannot heal on its own. Because the internal opening remains exposed to the bowel, bacteria constantly re-enter and travel downward through the newly formed tract, creating a continuous cycle of chronic infection. To cure the disease, surgeons have to locate and eliminate that internal opening. Since that origin point is hidden deep inside the muscle, they must deduce its precise location based entirely on where the exit wound appears on the outside skin. This diagram illustrates Goodsall's rule, the diagnostic map surgeons use. The primary dividing the area into an anterior or front and posterior or back half. Goodsall's rule dictates that if an external opening falls in the anterior half, the hidden fistula tract will run in a straight, direct line from that opening to the anal canal. If the opening is in the posterior half, the tract follows a curved path to enter at the posterior midline. The exception is an anterior. By applying Goodsall's rule, surgeons are able to take an invisible internal infection and map it as a mathematically predictable geometric path, revealing exactly where they need to operate. This cross-section shows the internal complexity of these tracts, which are classified primarily by how they interact with the sphincter and the anorectal ring, the muscular boundary essential for maintaining bowel control. Low-level fistulas, such as the intersphincteric and superficial types seen at the bottom, cross through the muscle layers below the anorectal ring. High-level fistulas, like the high transsphincteric type, are wide open. But if a surgeon aggressively cuts open a high-level fistula, they sever the vital anorectal ring, leaving the patient with irreversible bowel incontinence. Before making a single cut, the patient is placed under anesthesia, and the surgeon inserts physical metal probes to gently explore the tract. Treatment is a fistulotomy. The surgeon simply slices the roof off the tunnel along the probe, converting the enclosed, infected pipe into a shallow, open groove. Because this happens below the anorectal, continence is preserved.
The surgeon then scrapes away or excises the unhealthy fibrous tissue lining the newly opened tract, which clears the infection and allows fresh, healthy tissue to heal from the bottom up. High-level fistulas require a more calculated approach, utilizing Gabriel's two-stage operation. Instead of cutting directly through the muscle, the surgeon passes a seton, a heavy silk tie or metal wire, around the deeper part of the tract that contains the vital sphincter fibers. This seton is tied loosely and left in place for weeks. As it is gradually tightened over time, the wire slowly cuts through the muscle layer. Crucially, application of the wire stimulates controlled fibrosis, meaning solid scar tissue forms immediately in its wake, holding the muscle firmly together and preventing it from gaping open. Curing a fistula in ano requires a mastery of architectural balance. By strategically dismantling the abnormal tunnel while simultaneously forcing the body to reinforce its own vital muscles, modern surgery breaks the chronic cycle of infection, finally allowing the body to close the breach for good.
It starts with an escalating pressure. A perianal abscess forms under the skin, filling with fluid and swelling against the surrounding tissue to create a sharp, throbbing pain. Resolution usually happens quickly. The abscess either ruptures on its own, or a doctor makes a small incision. In the weeks that follow, the wound finds only a tiny hole that occasionally drains small amounts of fluid. The pain is gone, leading the patient to assume the ordeal is over. But a few months later, the pressure returns. The exact same abscess swells up, ruptures, and drains all over again. That initial rupture did not clear the infection. Instead, it carved out a permanent, hidden physical defect in the tissue, ensuring the abscess will keep coming back. Looking at this section of the anal canal, we can see exactly what that physical defect is. The initial drainage left behind an unhealed tunnel that connects the inside of the anal canal to the outside skin. This structure is called a fistula in ano. Because the internal end of this tunnel remains wide open to the anal canal, bacteria flow into the tract. The body's natural healing response activates the problem. The outer layer of skin tries to heal and closes shut over the external opening. This traps the bacteria inside the tunnel, causing the surrounding tissue to swell and become infected. In a clinical setting, this trapped infection is often characterized by raw, pink granulation tissue pushing out from the mouth of the fistula, while the surrounding skin and tissue become hardened and indurated. This biological trap makes the formation of a new abscess inevitable. The patient is locked into a repeating loop of swelling, rupture, and temperature. If left untreated, the continuous pressure of these recurrent. When the pressure from the trapped infection cannot vent properly, the pus carves out new pathways. The infection branches off, creating multiple anal fistula, with several distinct openings on the skin. If the ischial rectal fossa, the tunnel can spread laterally, wrapping around the posterior side of the anal canal to invade the tissue on both sides. This massive is known as a horseshoe fistula. It leaves the patient with painful, discharging external openings on both the left and right sides. As the physical geography of the infection shifts, surface-level treatments fail to reach the complex network expanding beneath the skin. To break the cycle, the hidden primary suspect, requiring a chest, the surrounding skin lacks any hardened induration. The crucial step for a surgical cure is mapping the tunnel's trajectory against the anal rectal ring. This dividing line determines whether the defect is a high-level or low-level fistula. Low-level fistulae open